Good. Don't worry, Dr. Mazumdar. I'm just going to make you you to be able to talk. Sorry, just.
Is it okay? All the questions are okay?
Yeah, all the questions are okay. So I got them there. So when do you want me to play those questions?
Maybe after the talk, or
you in the middle you can ask when you want me to put any of them if you want. Whenever you want, I can put them on.
So the time is 10 minutes, right, for the talk?
Yes, we are fluid.
Yeah.
And discussion.
So I think as I go as I proceed on during the talk, you can put the questions so that at the end of the talk, maybe most of the people have answered. Or
okay, great, thanks. So thank you. So good afternoon and welcome everyone to the fourth and final day of this International Pediatric Brain Tumors course. We have had 3 fantastic days with excellent lectures and great discussions. And on this day, we are going to have controversies. We are going to address controversies. As you know, neurosurgery is about controversies. There are very few things black and white. And we have got 4 eminent speakers who are going to take us through. They are going to give us a presentation. Then we will have an open discussion. We have some few polls as well. I will try to put those polls as we go along. So the first controversies that we are going to address is on cerebellum mutism, and Professor Dr. Priya Mazumdar from KEM Hospital in Mumbai, the director of pediatric neurosurgery there, is going to take us through. It's an honor and pleasure to have Dr. Professor Mazumdar to give us this session. He's the editor of the Journal of Pediatric Neurosciences. Thank you very much, Professor Mazumdar. You should be able to, let me just make sure that you should be able to share your presentation.
Yeah. Is my presentation seen?
Yes. I think you have to just maximize it.
Yeah. Is it okay? Yeah.
Yeah, thanks.
Thank you, Naren, and it has been a very fantastic feast for 3 days, and I really enjoyed it because it's our area of interest, and the more you discuss, the more you talk about it, the more you realize that there are many things that we don't understand, or rather, there are new insights from the experts all over the world, and I'm very glad and happy to share and learn from their experience as well. So today we are going to talk about cerebellar mutism. And this is rather a very old known topic, but still a lot of things are not clarified, or there is evolving literature on this. And we continue to face this problem because now over a period of time we are operating more and more posterior fossa tumors. There is a lot of experience around the world. So let me take you through some aspects of cerebellar mutism syndrome. So this was described first by Hirsch et al. Way back, but the real clinical entity was depicted by Professor Harold Rickert in 1985. And as soon as that was popularized, more than 400 cases have been reported since then. It has been known by various names. So some of the names I've written here. It is known as transient cerebellar mutism. Some call it dysarthria, some call it just mutism syndrome, or posterior fossa syndrome. So we are very well versed with the midline syndrome for posterior fossa. But here, there have been loose terms, and we need to sort of get to know what is exact mutism and separate it from the other causes of mutism. So in 2016, the Einstein Delphi group gave a consistent statement. So now it is known as the post-operative pediatric cerebellar mutism syndrome. Mind you that this is mainly seen in pediatrics. It is also seen in adults, but this kind of syndrome has been coined in the pediatric literature. It is post-operative. So normally when you operate on a posterior fossa tumor, you normally see this kind of a transient syndrome. It is also observed. Similar kind of picture is also observed in other cerebral degenerative diseases or cerebral diseases as well. To separate those from the post-operative cases, this is the final definition And we should refer now to cerebral mutism as post-operative pediatric cerebral mutism syndrome. What happened? I'm not able to. Okay. So the incidence is varied in the literature. It varies from 8% to 32%. And the reason that it is so variable, it is mainly maybe sometimes just not recognized or partially recognized, but in various groups it is up to 30%. So the advances in functional neuroimaging surgery, we are excising more and more tumors radically. The timing during the surgery, all this is caused increased survival of the children with post-operative posterior fossa tumors. So no, there's no wonder that this syndrome is seen increasingly and variably well in the literature. The anatomical substrates for this is, as you know, the cerebellum is not only concerned with coordination. It has got huge other functions as well. So it is concerned with balance and coordination, which is not associated with, but it is also concerned with higher cognitive processes. And you know, the vermian, the paravermian nuclei. As you see, the schematic diagrams tells you that it is concerned with cognition, it is concerned with memory, language, and higher functions. So cerebellum cannot be just a modulatory center for the cerebrum or the control of coordination and balance. So the recent literature, the literature on cerebellum, I try to just concise the literature on cerebral mutism syndrome. So we know that the dentatorubro-thalamic tract is the culprit for the cerebral mutism syndrome. And akin to cerebral mutism syndrome, there is something known as hypertrophic olivary degeneration, which is seen in the inferior olivary nucleus. This syndrome, this degeneration mimics cerebral mutism syndrome, and there is a common pathway which is observed. So the Gideon-Mollaret triangle, which is radiologically seen on a post-operative imaging, you can see an increased signal on a delayed post-operative imaging. It is concerned with the inferior olivary nucleus and the contralateral dentate nucleus and the red nucleus. So the central tegmental tract, the superior cerebellar peduncle, and the inferior cerebellar peduncle are all involved in the manifestation of the syndrome. So they feel that, you know, that as per the hypertrophic, the HOD, what we call it, has got similar substrate as a cerebral mutism syndrome. So as we see, there are many other things which can mimic a cerebral mutism syndrome. So bilateral thalamotomy, you can see sometimes this syndrome mimicking bilateral thalamotomy for Parkinson's disease. Okay. The lesions in the supplementary motor cortex or bilateral edema in the pons, cerebral peduncles, periaqueductal gray matter, substantia nigra, and preoperative brainstem compression involvement. So these are some of the changes that we see in these areas. So pathophysiology. So it is immediately seen after surgery. Maybe in a couple of days you can see this, and usually the bulbar dysfunction is caused by the damage to the cranial nerves in the brainstem. Sometimes you can see a delayed. So the reason that the cerebral mutism syndrome manifests because of the cerebral perfusion defects. There is vasospasm, there is focal hyperperfusion, and because of the hypometabolism, there is decreased oxygen supply, and it leads to anoxia or hypoxia and disruption of the tracts, the dentatothalamo cortical tract. So there is another syndrome which is known as the cerebellar cognitive affective syndrome. Now this is seen usually when in the developing cerebellum phase. So when in the intrauterine life, if there is the first 3 weeks or 6 weeks, if there is a defect in the developing cerebellum, it might lead to autism later on. Now, whether these patients or this syndrome is akin to the CMS that we see in the post-operative period. So this is another thing that is being looked at to elucidate the the risk of developing a CMS in the post-operative period. So pathophysiology, as I just mentioned, so what can lead to cerebellar hypoperfusion or the disruption of the tracts? So surgical manipulation of the cerebellum, if there is an intraoperative coagulation of perforating vessels, prolonged retraction of the vermis, or if there could be arterial embolic occlusion of the vessel. So in whatever leads to hypoperfusion may cause a global hypoperfusion, and it may involve the left prefrontal motor cortex, the supplementary motor cortex, and the prefrontal motor cortex as well. So whatever happens is cerebellum has a distant effect. It has effect on the cerebrum, which leads to all the components of the cerebellar mutism syndrome. So one thing is the perfusion defect. Second thing is the edema. The edema is, as I just mentioned, it is seen in the peduncles and in the brainstem, and it is very well defined by the DTI signal seen on detailed MR studies. So whether there is a role of systemic steroids, which will give transiently to just alleviate the symptoms, or is it related to the axonal injury or some neurotransmitter dysfunction that needs to be seen. Only the good part of it is that many of the patients recover now, because maybe it is because of the neuronal plasticity, or sometimes whatever the ataxic dysarthric speech that we have, it is reassigned elsewhere somewhere in the cerebellum, or maybe the cortical functions take over. So here, there are different studies in the literature which have looked at the cognitive and the behavioral issues related to the cerebellar mutism syndrome, and the prominent ones are Palmer, Hudson, and Steinbock. These are three papers which are there in the literature, and they have found statistically significant difference in the processing speed, the attention, as well as the cognitive efficiency. So definitely long-term effects of cerebellar mutism are really more disturbing, and they have done it on the neuropsychological assessments as well. They have proved it on the neuropsychological assessment. But the only problem is that in this, the children of this age group, it is difficult to get a robust neuropsychological assessment, or these patients have brainstem dysfunction, or they are morbid, so they might not be cooperative for neuropsychological assessment. But generally speaking, as if this syndrome lasts for which is supposed to get resolved in few weeks time, maybe it may last for 1 year or 2 years, or even at 10 years, people have finding this cognition, behavioral, and speech deficits. So this has a long-term effect, and it is quite distressing to the family. So what are the risk factors which are definitely identified? So brainstem involvement by the tumor, there is a high risk. If it is a medulloblastoma, the risk is 2 to 3 times higher than other tumors. The tumor size is also important. Brainstem compression also is an independent factor. The Vermeer incision, just now there was a question. So Vermeer incision has 2.6 times greater risk for developing mutism syndrome, blood transfusion, and young age. So these are the factors which are responsible for CMS. There are negative predictive factors. So the length of the Vermeer incision, the gender, it doesn't matter. The type of neurosurgeon who has operated pediatric or adult, and pre-existing edema or swelling in the cerebellum. These are negative predictors for CMS. So here in the schematic diagram, which I have taken from the Bristol group, who has published this in World Neurosurgery in 2021, they have nicely summarized this. So if you can see, significant risk factors involve medulloblastoma, posterior fossa midline, brainstem involvement, large tumor size, and Vermeer splitting incision. So the answer to the question was the Tilo-Wheeler approach is more suitable than Vermeer splitting incisions. However, in some studies, it is argued whether really Tilo-Wheeler approach has got decreased incidence of CMS. So there is a little bit of controversy there as well. But unproven risk factors are definitely the extent of tumor resection or infection, hydrocephalus, gender, do not significantly matter in the development of CMS. They might be just contributing, but not, say, mattering per se. Potentially risk factor is that if the patient has got pre-op language impairment, or if they are autistic or something, that also can affect the CMS. Treatment-wise, there is no established treatment. So some drugs are tried. These are anecdotal reports. So these are newer vasoactive drugs aimed at increasing the circulation. So and the mood changes. So fluoxetine is supposed to elevate and affect and improve some cognition on some speech deficits in this patient. However, it is all anecdotal. But the long term is only rehabilitation, where speech therapy forms an important component. However, how we can prevent it how we can minimize the incidence of cerebral mutism syndrome. So we could definitely avoid splitting the vermis and lateral retraction of the hemisphere. Nowadays, many people do not use any retraction for posterior fossa surgeries. You could use telovelar approach. You could use piecemeal resection rather than en bloc removal of the tumor. Certainly, intraoperative neurophysiological monitoring has got its role for monitoring the cerebral cortical functions as well as cranial nerve monitoring. And there has to be less aggressive retraction, as I just mentioned, and avoidance of ultrasonic aspiration. The prognosis, now this is most important. This is where the controversy comes, that still we are not understanding this phenomenon very well. So there are significant cognitive and behavioral disturbances, and this has led to significant financial effects on the healthcare system as well as distress to the family. Now, about 2/3 of the patients suffer from all these motor to speech deficits maybe a year after the resolution of the mutism, and sometimes it could be a permanent sequelae. There are some non-motor related speech disturbances as well. So these patients usually have problems with fluency and word finding difficulties and grammatical disturbances. So what can be done? So what the focus point is that we have to have standardized preoperative or more efficient surgical planning and post-operative management. We can identify the risk factors for CMS and try to avoid them preoperatively. These neuroimaging techniques can be very helpful. Functional neuroimaging, functional MRIs, and nuclear studies sometimes can be very helpful. And And as I just mentioned, robust neuropsychological assessments need to be done. And there are a range of therapies which are used for optimizing rehabilitative therapies as well as some drug therapies which may affect the quality of life patients with CMS. So these are the references which in the past couple of years, a lot of papers have come in child nervous system as well as world neurosurgery, where this has been discussed in detail. However, the entire thing revolves around the dentatorubro-thalamic tract and the cerebellar, understanding cerebellar functions and processing of motor, non-motor functions of the cerebellum, and trying to sort of get some evidence about how we can sort of understand and tackle this problem in the future. Thank you very much.
Thank you very much, Professor Mazumdar. That's a great summary of the various aspects of cerebral mutism and the controversies. You first of all, in terms of definition, in terms of at what point do you consider a patient has cerebral mutism and the degrees of cerebral mutism, so what's your thoughts, and if I can then ask our senior faculty. Thanks.
So as I just mentioned, this post-operative pediatric cerebellar mutism, which is a new definition, which is with that. So it is being defined. So it has a delayed onset, and the components are specific. So it has got ataxia, hemiparesis, hypotonia, dysphagia, and emotional lability. Now, normally it starts about 1 to 3 after about 2 to 3 days, and usually it slowly resolves over a period of few days or maybe a few weeks. But if it prolongs, most of the time the motor component or the speech component prolongs. So it is described as ataxic dysarthria. So the limitation, it is self-limiting. The syndrome is self-limiting for maybe a few days to a few weeks. But so the main concern is the cognition and the speech deficits, which can prolong for maybe a couple of years. That is the most disturbing thing. So, although the patient recovers from the mutism per se, because of the cerebellar involvement in memory, speech, and cognition, it has effect on the cerebral function as well because of the circuit. And that disruption of the dentatothalamic or rubothalamic tracts, the hypoperfusion there's no way to predict the recovery. And many other factors, the brainstem involvement, the brainstem compression, all these factors also add to the problem of in terms of rehabilitation.
Thank you. And when I see patients with cerebral mutism, we put so much emphasis on the actual speech rather than get any neuros. I can't remember getting formal neuropsychological testing, and then following up with formal neuropsychological testing. Usually, the surgeon says, "Oh, it most likely will improve." And and do you do formal neuropsychological testing and then followed up, or then get rehab for that?
Yeah. So what happens is to the neuropsychological testing, not in the immediate post-operative period, but if it is delayed, then it all depends upon the age of the patient and the compliance. The neuropsychologists are not very comfortable in getting the formal neuropsychological testing done because of the age of the child. They might not be very cooperative for detailed neuropsychological assessment, not only because of the mutism component, but because overall the posterior fossa syndrome, the hydrocephalus, the brainstem issues, the patients are not cooperative. So even if it is a normal child, small child, they have a problem with a formal neuropsych assessment. So it is a general. It's kind of a sort of a neuropsych assessment done tailored to the population that we are dealing with, in the best language and understanding from the patient, from the parents. So we get a rough idea. So a robust neuropsychologist assessment only is done maybe in elder or a little bit older children who are more than 10 years of age, or so, in the adolescents, not in the small child.
Smart. And there's a question for you from Dr. D-Tech class about to comment about fluoxetine.
Yeah, the fluoxetine is usually these are anecdotal reports, so there is no evidence that this works. So the fluoxetine is supposed to just dampen. As we know, flunil is a mood elevator, and it helps to. It's like an SSRI. The serotonin neurotransmitter levels are increased, so it gives a feel-good factor. And that's how it is supposed to a little bit affect the cognition and try to improve the cognition and the attention span, the speed of processing. It is a common drug. It is like an ADHD that we are dealing with, like an ADHD. So fluoxetine has been found to be effective in 2 or 3 patients. So it is not that there have been robust studies on that.
The other, if anyone wants to ask question, if you put your video up, then I will get you a microphone to talk, so that way I know who wants to ask questions. Otherwise, just put your name on the chat box that you want to ask a question. I will open up your microphone. In terms of there was that big recent study in Europe on cerebral mutism to look at which approach was most associated with it, whether it's telovelar or transvermian, and that came actually that if anything, telovelar was, if I'm right, was worse. Professor Mazumdar, do you have any comments on that? Then we can get Professor Grotelius to come in. Thanks.
Yeah. I just mentioned that the risk factor for development of CMS, it has been identified that Vermeer incision should be avoided, because this, according to the recent topographical representation of the cerebellum, the Vermeer, the paravermean nuclei are also involved the circuit. So the nuclei apart from the dentate nucleus, the fastigial and the globose and emboliform nuclei also have some components. So if you split the vermis, you are disrupting some tracks in addition to the dentatothalamo cortical tract. And this has been identified on the functional neuroimaging. So as the risk factor, yes, vermin splitting should be avoided. But if you ask me whether telovelar will completely avoid cerebellar mutism, then you are right. That some studies have proven that the approach doesn't matter to that extent. So you are just getting a feel-good factor that you are avoiding any incision of the vermis. But as I just mentioned, this may not. This is one of the small factors for developing CMS. The patient still could have a mutism in spite of the telovelar syndrome. You are just trying to minimize the mutism by using the telovelar approach.
Thanks. Thank you. Professor Groton-Hughes, can I get you into this controversy? Thanks.
Yeah, well, Dr. Muzumdar gave a beautiful overview. I mean, this is a syndrome that we all know as a postoperative complication in cerebellar tumors. And I just indeed wanted to put emphasis on the fact that telovelar is a beautiful approach because we don't have to split normal cerebellar tissue. That's perfect. That's like opening the sylvian fissure. I mean, you can go through the temporal lobe, but opening the sylvian fissure is less damaging to brain, and that in itself is already a positive by-effect. But indeed, there were several studies showing that there was no difference in incidence of cerebellar mutism syndrome. And Naren, could you allow me to share my screen?
Sure, just a second.
I'll stop sharing. I will stop. Yeah.
Okay,
I will.
You should be able to share, Prof. Otherwise, I'll just.
Okay, let's see. No, it is still disabled.
Sure. I will just get it right.
No, that's fine.
No, I already got it. Yeah.
No, okay.
No, you should be able to do it now. Thanks.
Let's see. Yes. Let's see. That's this one here. Yeah.
Yes.
And what you see here is because it is complex. It's very complex to. So this is actually from, and you mentioned these people. Schmamann was very early on already with studying cerebellar mutism, and the Icelandic group, together with Professor Euler in Copenhagen, did a lot of work. And this what I have from them, and this clarified it much more. There are three typical types of difficulties with the cerebellum. It's behavioral, it's motor deficit, and linguistic. And if you then go back, and then the only thing here, this is cerebellar mutism sec. If you see, this is a cerebellar syndrome here. This is a transient one. It's only ataxia, nystagmus, dysmetria. But all this together here is the posterior fossa syndrome. So this is because it is so confusing having all these different words on it. And this actually, if it is only in whining, apathy, attention problems, this is what is called the cerebellar cognitive affective syndrome. So that's only, again, one part of it. But you see how they are all intermingled?
Yes.
And in this mutism, it's the dentate rubrothalamic tract. And often people ask, why are the symptoms delayed? And Dr. Muzumdar nicely showed this is the so-called cerebello-cerebral diastasis. That it has long been doubted that it is even possible because everyone knew already for 3 decades the cerebellar diastasis. If you have, and let's say, in hemorrhage in the thalamus, the end organ in the cerebellum will also go down. And it was doubted that the reverse, so the problem starts in the cerebellum, and you get then problems in, well, all the way up to the thalamus. And you can prove actually that there is hypoperfusion in that area after a few days. And that is why we see the delayed symptoms. And there was one point that what I learned is actually that it is also left-handedness. That is really, and it was more or less, it's not, let's say, a hemispheric pilocytic astrocytoma has hardly any risk of developing that. It's the midline tumor, it's the size, because then both sides, the dentate rubro-thalamic tract is already compressed. And we have done preoperative studies where they are already not present anymore, and they develop mutism. So a left-handed boy, that is in gender again, a left-handed boy with a medulloblastoma has more or less 100% chance of having a post-op cerebellar mutism. And I also want to warn the colleagues saying to the parents that it is only transient. That means in a couple of months, they will be fine. To be honest, there have been studies studying these children for more than 20 years. They will have still symptoms. They never reach the normal level again. I mean, they improve, but they never really reach that normal level again. And that is just what I wanted to, let's quickly go out here because I didn't want to, where is now my, hey, I want to see that I stop sharing here.
All right, it's always sometimes difficult. If you go to the
top, well, now you have to go now to the full screen again.
If you go to the top,
yes, and I can, yeah.
And while Professor Groton is trying to figure out, I always find stopping is harder than starting. Can I just get Lual and Professor Paediatric, do you have any comments, Lual?
Yeah, thanks so much, Nalan. Firstly, nice to see all of you. Andre.
Nice
it was a really good talk. Really good talk. Thanks, and you've covered all of these things exceptionally well. Just two comments, one on the study you mentioned, and then to follow on Andre's comments. He often covers a lot of the things I wanted to say anyway.
Sorry about that.
So thanks, Andre. No, it's a compliment. It's the highest compliment. It's just, when one looks at the approach, we would always like to use approach that respects anatomical planes. So like Andre said, I think every single one of us would prefer using a telovelar tonsillar approach. I think it's more the anatomy of the tumor and how much of the vermis is invaded before the actual approach that has more of an impact. I mean, if one can preserve the vermis, I think all of us would almost always try and do that. So I think that was a little bit of a shortcoming on the findings of that study. Now, the other point I wanted to just ask Data was, I wasn't aware that Zopiclone was used in this context. I know it was, mentioned in sort of comatose patients for traumatic brain injury, but that would be a really interesting thing. Just a comment on that, on the Zopiclone use for mutism.
Yeah, so actually, all these mood elevating drugs, I would say, Zolpidem and Fluoxetine, they have absolutely anecdotal. So there is only one or two patients. I just mentioned it so that to complete the list that there is whether they have they are vasoactive drugs or they are more causing the neurotransmitter, the serotonin level to rise and giving mood elevation. That's nobody knows the exact mechanism, but it is an observed phenomenon that the drugs like Zolpidem and Nimodipine and Bromkreptin, as well as Fluoxetine, there are anecdotal reports of improvement. So they are now researching whether it could be used in these drugs, but no solid evidence is there for this.
Thanks. Thank you. Can I just get Dr. Boop? Dr. Boop, from your extensive practice, have you come to any tips or tricks to avoid cerebellar mutism, you think, from your practice there? Let's see, Dr.
No, I don't. I don't think it comes from the vermis. I think it comes from the dentatorubro-thalamic tracts bilaterally. Ezio De Rocco says that in Rome, when they do posterior fossa tumors in kids, they start out by resecting the vermis as access to the tumor, and the incidence of posterior fossa syndrome there is no different than it is anywhere else. So I don't have a solution for it, but it's a horrible thing. And I agree with Andre, it is not transient. They may walk and they may talk, but they're never good kids again.
Now, how much is the retraction to do with the whether it's a telomeral or transvermial? How much the retraction has an effect, fixed retraction and not fixed retraction? And I think if I'm right in that the Danish study, there was a mention that it might be related to heat of the CUSA that possibly injures the pathway. Any thoughts on that? Those things, Dr. Boop or Professor Grotanius or Professor Mazumdar?
I don't think it relates to retraction. I think if you look at the relationship of the dentate nucleus to the splayed out cerebellar peduncles, it's millimeters away, and I think that's what gets damaged. Yeah. And it makes sense when you look at all the studies showing that the larger the tumor is or the more splayed the tracts are, the higher the incidence of posterior fossa syndrome. We haven't used fixed retractors in 20 years, and we still see it quite often. So
I fully agree with that. And it is, and also not the heat of the CUSA. It is typically where you see also, if you look very well on the pre-op scan, if you do that also with DWI, it's in the superior part where it comes very close to the tract, where the tract comes from the dentate nucleus, already moving towards the red nucleus. They are absolutely, but sometimes they are simply even preoperatively not visible on our MRI scans. And if you start to dissect that and to be realistic, there will be disruption of that. Even so, it is not retraction; it's the removal of the tumor, and we have heard it is piecemeal rather than en bloc. I think en bloc would be very difficult. It is only possible in the smaller types, but it is this superior part where you end up having that. If you really have low lying, so in the, let's say at the foramen of Magendie tumors, you don't see this. It is the superior part where it is dangerous, and this is not heating. It is not CUSA, and it's not retraction at all.
May I comment on this?
Yes.
So here, So the identified risk factor is medulloblastoma and not pilocytic astrocytoma or ependymoma, what they've identified. So I understand that what Dr. Boop and Dr. Grotanius are saying that the midline medulloblastoma causes the effect on the lateral nuclei, maybe the dentatothalamus going on the superior cerebellar peduncles, and that may cause hypoperfusion, that may cause the diastasis that is mentioned there. And the excision also now, it has been identified that I understand, I remove the tumors superior to inferior. I never go down and from near the foramen magnum or the C1, C2 region and then work upwards. So what I do is end the rapid internal decompression, and the tumor just literally falls down into your view. I operate in sitting position. So I feel that the superior, the more less injury you do to the superior pole of the tumor, probably you have less interference with the superior cerebral peduncles or the dentatorubberothalamic tracts. So I am wondering that pilocytic astrocytomas in the midline are not identified as risk factors for cerebral mutism syndromes. Any comments on that? Because you are working in the same area.
I think I agree with that. That's true. Yeah. We still don't have the solution. I mean, if we really know how because I have never seen, and probably you also not, preoperatively a child with a large medulloblastoma in the midline already presenting with mutism. It is never a presenting symptom. That makes it very frustrating for us as surgeons to realize that it is part of what we do, and even in let's say even if you would not go for total removal, still you can end up with that. So I'm intrigued that apparently this stretching out of the bilateral tracts is not causing it, but then suddenly what we do to remove it is leading to this. It's intriguing, and because if we know how to prevent this, that would be very important.
Do you think hydrocephalus and preoperative hydrocephalus and brainstem compression or involvement would mask these symptoms of mutism?
No. I think the symptoms of I don't believe, because the symptoms of mutism, you know that if you see that child in the same evening after surgery is fine, next day you see this whining child not reacting to you, and to the parents, they are devastated, you are devastated. I mean, we never see these symptoms preoperatively at all.
Yeah. I agree.
Yeah, but it's an intriguing thing, and I am happy that there is a lot of study going on to find out more. And we have, the final goal is that we can prevent this, or even have better possibilities of treatment, like treating this hyperperfusion or preventing the secondary effects. So it's good that we have all these ongoing studies.
Dr. Boop, do you have any thoughts on what Professor Mazumdar said about midline pilocytic not having the same effect if it is playing the nucleus? Okay.
Well, I think I would agree with him. That's more common in medulloblastomas, and I do the surgery the same way he says he does it, except I do it prone instead of sitting, but I go over the top of the tumor and follow the margin just like you said. So I do, Zoltan Patey is our head of neuroradiology at St. Jude, and he's been meticulous about doing tractography on the kids who develop it versus the kids who don't. And it does look like it's bilateral disruption of the dentatorubro-thalamic tracts. So I really think that's probably the key, but I don't know how to avoid it. Unfortunately, the midline fourth ventricular medulloblastomas are generally type 3, type 4, and those are the ones that require extensive resection for those kids to survive. So it's not like you could leave residual tumor there to try to prevent it.
That's true. Mm-hmm.
Yeah.
Thanks. In terms of, I have not come across the tractography for cerebellum. How good a tractography do you get for the cerebellum, Dr. Boo?
I didn't hear, say that again.
Sorry, in terms of the tractography for cerebellar pathways, how good a pre and post-op tractography can you get?
Well, they do all of their scans in children sedated with propofol and 3T MRI, so it's really high quality.
Yeah, and you can see these tracts going into the cerebellum.
Absolutely.
Yes, Absolutely. You can see where the dentate nuclei are.
Yes, you can see.
The other question is, for when we do operations on supratentorially, we have a neurophysiological monitoring. Is there any role for neurophysiological monitoring for these cerebellar tumors?
I think what has been what Dr. Kritinis said just now, that these are the distant effects of the surgery on the cerebellum. So the monitoring is usually done to identify changes in the premotor, motor, or prefrontal cortex, and that gives you cranial nerve monitoring for the lower ones, and the monitoring of the MEPs and SSCPs for the distant effects. So that's how the combination of those helps in monitoring the situation during surgery.
The other question is that in terms of, I think that in France, they're going to start a study where they are going to biopsy posterior fossa tumors, confirm it's medulloblastoma. If it is medulloblastoma, then treat with chemotherapy, try to shrink it, and then after that operate on it. Do you have anything like that in? Have you anyone tried pre-op chemotherapy for with a biopsy for medulloblastoma? And any thoughts on that, Professor Mazumdar?
At least in our center, as what is the standard of care and the recommendations go, I think medulloblastoma, you need to remove it radically, safe and radically as far as possible. According to the molecular typing, if you go by the molecular typing, then you don't need to take extra risks to cause deficits because it is very sensitive to chemo and radiation. So I think a safe radical excision helps the oncologist to maximize the therapy, adjuvant therapy, and not give too much high dose of radiation or keep. So I'm not quite sure that preoperative neoadjuvant in medulloblastoma is on the cards. So we would radically excise the tumor, safe radical excision as possible. And the oncologist would return the patient back to us for resurgery if something goes wrong there.
Sure, thanks. Dr. Boop, do you see any merit in a pre-op chemotherapy before and shrinking the tumor before excising?
You know, these kids present sick, and I don't see a way that you could do that. Typically, they have hydrocephalus, they're lethargic, they're bradycardic. I don't see how you could give them neoadjuvant chemotherapy, particularly without a tissue diagnosis.
No, I think they're in France. They're going to do a biopsy to get a tissue biopsy, tissue diagnosis before. I think the British guys are a bit reluctant to join because the thought of having to do a posterior fossa operation for an open biopsy and then close and then chemotherapy and then come back doesn't sound great, Professor Grotenius?
No. That would be very tough to do. I mean, already putting a child to this posterior fossa
posterior fossa.
It is for non-surgeons. Calling it a biopsy seems a way simpler procedure than tumor removal. But please, an open biopsy is more or less the same procedure, only you stop earlier when you have some tissue and it's fine. But you leave a lot of tumor behind. So there is still a lot of space occupying lesion there. You should take care of the hydrocephalus then, of course. I would be very reluctant to do that. They are also hemorrhagic. I mean, you have bigger chance of having maybe a post-op hemorrhage, a delayed one in a couple of hours or 12 hours. No, this would be at least from neurosurgical thoughts that I have on these lesions, I would be extremely reluctant to do that and explain that to the parents that is a wise decision to do.
Makes absolute sense. In terms of in terms of this posterior fossa syndrome, mutism, however you call it, I think parents don't properly usually get, my impression was that the patients don't realize when they are given consent, the distress that causes after the operation, because that's a bit of a shock to the parents. And usually the surgeons say, oh, it will improve, and then they buy time and move on. What's the best way to prepare parents before the operation for this, Professor Mazumdar?
Yeah, since now this entity is on the card, especially if I'm dealing with the medullo, or for that matter, any posterior fossa, we always counsel them for a possible long-term issues. At that moment of time, the patients are sick and they're distressed, and there is a lot of things we need to deal. The tumor, the hydrocephalus, and the post-operative course, maybe they require some ventilation and CSF drainage and all that. So all these things revolve initially around that other thing. At that time, really, even if you explain these patients about all these things, it doesn't sink into them, because the child is sick and we have to get him relief in his headaches and vomiting and all that stuff. So the relatives, even though you explain them, may not understand, or they are not in the position to imbibe what we are telling them in the long term. So I think we briefly mentioned them, but as the days progress, when we counsel them daily and the patient is coming out, we just prepare them at that time for a possible, long-term overall if they demonstrate with some emotional lability and, all the speech or cognition issues, which are not, and the relatives themselves ask, now my child is getting better, but why is still not recovering well? So at that juncture, I think it is a proper time to engage them into this thought. If you explain them at the time of surgery, at least in our patients, they don't understand that the gravity of the situation. If I talk about mutism at the start of or before surgery,
I think there's a lot of firefighting to do first before we come to that point. Dr. Boop, is there anything that you guys in your team in St. Jude and Labornia do anything in terms of rehabilitation that you want to mention for these patients? Is there anything special for rehabilitation, or is it just a standard rehabilitation?
That's a good question, Aaron. We've tried different types of drugs for a period of time. There was a suggestion that maybe Zoloft would hasten recovery. I don't have an answer there. I will say that there are times where children have big ventricles post-operatively and they have cerebellar mutism, and you end up putting in a shunt, and within a day or two, they seem to be dramatically better. So I do think that at times the hydrocephalus can cloud the picture.
I see your point there. Sometimes, you're looking at like yesterday when we were talking, you're looking at the ventricle and saying it's large, but it's not as large as pre-op, but it's certainly much larger than how it should be. And so sometimes the treatment of hydrocephalus might be delayed. Dr. Hughes, any thoughts?
No, I agree with that. I mean, we have no, like the sopriclone that was mentioned, and I know that we also try to methylphenidate, the Ritalin, and it all has, some people describe it that there are some benefits, but simply we don't have a proper treatment. So the goal is prevention. And we should look into, like we do with brain trauma, when we can't change the primary trauma, we should try to interfere with all the secondary effects that can occur. And you know from brain trauma how difficult that is, and it will be the same here. It's extremely difficult to develop a kind of treatment, and also the numbers are not that high. So there are not thousands of them on a yearly basis, so that you can do large studies. So this will still be very difficult to find out.
At what stage of the mutism would you really consider that hydrocephalus is causing the problem? So if you're giving down a few weeks and you see dilated ventricles, the ventricles may not come down, and the patient is relatively well with the mutism. So would you address the hydrocephalus at what time? Would you really address the hydrocephalus thinking that that is the cause? That Dr. Boop just mentioned about it.
Treating hydrocephalus, I mean, it's always a kind of ventricular cosmetics. I mean, if we want to have on a skin with nice looking ventricles. And that was the same with ETV, that the ventricles never really regain size. And initially, when we started with ETV, that was where pediatricians were very angry because they knew the very small ventricles after shunting, and we all considered that as being the norm. So it is extremely difficult. We have to look to the secondary signs, not only the size of the ventricles, but look to the third ventricle. If there is a kind of waste inside the size, means there is no pressure in size. If it is still a little overly shaped, I look to some more of these secondary signs of still some elevated pressure that will bring me to doing that, or even do some telemetric ICP to just know if there are some nightly waves that we don't discover. Especially in these kids, we are rather proactive in trying to improve their own condition, but also their brain condition, but not overly aggressive towards the image of the ventricular system on a scan.
That's great.
Yeah, I agree completely. It's the gestalt, it's the bulging posterior fossa incision, it's the child that persists in vomiting, it's a spinal tap that shows elevated pressure. It's more than just the child who's not talking and is lying still in bed.
Exactly. Yeah.
Thank you very much.
They really don't look well. They don't look happy. These are children in distress. If you see them, they are not. Let's say not only not talking, and you just. I mean, the simplest thing is to ask the mother or the parents. They say, "My child is. This is not my child. She's different or he's different." Absolutely, that's so obvious.
Absolutely, it will be not that it would be nice to see some animal studies where they put some electrodes and stimulate various pathways and see whether you get these things. But I think functional neurosurgery and pediatric neurosurgery are two different animals, and probably it will be nice to know. But I don't know whether it will make much difference. But thank you very much, Professor Mazumdar. That was a great debate and discussion and overview. We'll all learn from it. So thank you very much. So now I'm going to invite Professor Marek Mandera from University of Silesia in Katowice, Poland, to provoke discussions regarding when do you stop continuing with the excision of craniopharyngioma. But I will let Professor Mandera frame it as he wants. Thanks.
Thank you, Naren. Can you hear me?
Yes, absolutely.
Okay. So I would like to return to the topic of craniopharyngioma treatment and discuss in such an excellent group of experts the controversy regarding the choice of the optimal treatment strategy. I was talking a lot about these controversies during my day before yesterday talk. So here I intend only to present shortly first the background and then put for discussion 3 of our cases, if it is okay for you, Naren, and
absolutely, thanks.
All right, okay. So first, just to remind, I think for the most of us it is obvious, but just for reminding, as I said the day before yesterday, in the history of craniopharyngioma treatment, we can see the competition between 2 approaches. The first based on aggressive surgery with the aim of complete resection, and the second more conservative with partial tumor or subtotal tumor removal complemented with radiotherapy. The scientific grounds for such a more conservative approach provided Clark in 2013 in his review of the literature based on more than 100 papers. He demonstrated no difference in 1 or 5-year progression-free survival between the groups of total resection, this showed here, and the group of partial or subtotal resection plus radiotherapy. Also, the comparison of endocrine deficits before and follow-up after surgery showed clearly that aggressive surgery for pediatric craniopharyngioma is associated with increased rates of anterior lobe and metabolic dysfunction. You can see it in our experience, 50 patients, except for short stature and slow height velocity, which improved after surgery. The other factors like hypogonadism, hypothyroidism, and so on diabetes insipidus, and mainly obesity, all of them increased after surgery. So the fundamental fact which we should have in mind for further discussion on decision-making in craniopharyngioma is contained in this sentence, that although freedom from recurrence does correlate with extent of resection, we cannot conclude that more extensive subtotal resection leads to better outcomes than less extensive subtotal resection followed by irradiation. So we use in our everyday practice the algorithm proposed by Stéphanie Pouget and the Paris group, who classified the tumors and recommended kind of treatment based on the involvement of the tumor, the hypothalamus. So they found 3 grades: grade 0, when no hypothalamus involvement is found; grade 1, when hypothalamus is only displaced by the tumor; and grade 2, when if hypothalamus is really involved by the tumor. And they recommended in grade 1 and grade 0, where if it is only possibly total removal of the tumor, and in grade 2, partial removal or subtotal resection with hypothalamus preservation. As I told you during my last talk, the problem is what we precisely understand by hypothalamus sparing surgery, and how much of the tumor can we remove without damaging hypothalamus. So it seems there is no doubt that for tumors grade 0 and 1, total surgical removal of the tumor is the management of choice like this, and this tumor is absolutely clear, and I think we are sure of it. However, which is the best strategy for grade 2 tumors like this one? And there is no clear answer for that, and individualized decision in every patient has to be done. However, in my understanding, the main goal of our treatment is to preserve hypothalamus and optic structures, so our treatment should be aimed at the quality of life. So we don't want to be like Rambo, very effective, but causing lots of destruction around, and we prefer more conservative approach with better quality of life of the patient. So let us discuss 3 cases that we have treated. And first one, I showed it also the day before yesterday. So we have a cystic tumor, partially cystic, and the tumor and the hypothalamus is not clearly seen here. So what can we do? And I would like to ask you for your opinion. What management, what strategy do you prefer in this case? Rather conservative, so as I wrote here, drainage of the cyst with subcutaneous reservoir, and after reducing the cyst, possible evaluation of the hypothalamus, and then decision about kind of surgery, or tumor resection in one approach, and with which exact approach? Could you comment it, please?
Sorry, shall we, Professor Grottenhuis, do you have thoughts?
You know, I'm unmuted.
Okay.
Well, I have to, well, for this, I would, people say only drainage of the cyst. At least in my experience, this was usually get a rapid recurrence. So I would rather do the surgical approach. And I would not go in this case from a transsphenoidal, if you see that. it's more difficult. You can go to the tuberculum sellae and then over, but here the stalk would be in danger. So I think well, basal interhemispheric, most probably I would have to, of course, every neurosurgeon says that the same, show me more pictures. You want coronal and actualized, but I probably think, again,
here you have coronal.
Yes,
here
I think that the transcallosal would be giving a good access to this lesion.
You mean transcallosal transforaminal or transcallosal interferonical? Because the foraminal seems to be quite narrow.
I prefer transforaminal and then widening the foramen, transchoroidal fissure. So the interphonicele, at least in my hands, is not a very favorable approach. No.
Thanks, Dr. Boop. What would your preference be? Please, thanks. See. Sorry, Dr. Boop, I think you had to unmute.
It's difficult.
Some of the most functional long-term survivors that we have are kids with purely cystic cranios, where we've placed a stereotactic catheter to an ommaya, drained the cyst, and given focal radiation. And when it works, the children are absolutely very functional. When it doesn't work and you have to come back and resect it after all that, then it's miserable.
Mm-hmm.
So for 80% of the kids that are treated that way, they'll do great. For 20%, you have to go back and resect it after radiation, and it's not great.
What about interferon, Dr. Boop? They're solid, but it's mainly cystic. Would you contemplate interferon therapy?
I don't have any experience with it. Sergio Cavaliero probably has one of the best experiences with it, and in his hands, he's had very good success. For me, all of the intracystic therapies work great for 5 years or so, and then the tumor starts to grow again and you have to do something else. So I think of it as a temporizing measure to let a child get older to where you can do something more definitive.
Thanks.
Would it really matter if they're, let's say, the preoperative hypothalamic and pituitary function matter the approach? So if there is already not only diabetes insipidus, but let's say really hyperpituitarism already, would that make the choice for surgery easier? Or if there is still complete function, that you would go then for draining the cyst and giving radiation? Would that matter anything?
Dr. Boop?
Yeah.
We don't like to radiate very young kids.
No, for sure.
Help it. Is that what your question is? Oftentimes, children with these big cystic craniopharyngiomas present with short stature or headaches, and they really don't have a lot of endocrinopathy. So trying to preserve the function that they have, I think, is the goal.
Mm-hmm, mm-hmm.
Anyone in the chat room and so in the audience who have used interferon? Do you want to? Llewellyn, do you have any experience with interferon?
Thanks, Naman. We had quite a bit of experience with it when I was at Red Cross, and it seems to just be a logistic detail now that we don't have access to it anymore. It's become, I think, lifted to a Schedule 2 year anyway. So not I think most of the experience we had with it was really good. You need to follow a fairly tight protocol where you do something called a leak test to make sure your catheter is sealed around the exit point of the cranial, and the interferon doesn't leak into the ventricle. But generally, I mean, very much in line with what Rick said. It seems to hold these kids for a while. I mean, I'm interested here. Rick says about 5 years. I'm not sure that we had actual kind of time that we looked at, but that seems like a reasonable time frame. So it does seem to hold them.
And in terms of putting the catheter into the cyst, I have seen some not great outcomes. Dr. Boop, your trick to do you do a stereo tactic or do you use endoscopic? Because sometimes the catheters go around, or I have seen at least one hemorrhage and not been in the cyst.
Yeah, if it's as large as this one, I think you can do it either stereotactically or you can do it endoscopically through the ventricle. But with smaller cysts, I've certainly seen a catheter go straight through an optic nerve before. In those cases, I would do a small craniotomy and do it under direct vision.
But you probably also have seen, if you only have a catheter in Ommaya and then do some repeated emptying of the Ommaya reservoir, when that cyst is regrowing, it is actually not growing there where the catheter is, but it is in a different area. I have operated some cases where we found that catheter somewhere, but it looked like it was not in the cyst, although the surgeon absolutely said that he, during an open surgery, placed it into the cyst. So that part of the cyst probably collapsed, but then the cyst just around it starts to regrow.
Yeah, we had the same problems with some patients. When the cyst shrinked, the catheter seems to be out of the cyst.
Exactly.
So it led us to next surgeries and so on. So.
Yeah. What about terional or a subfrontal lamina terminalis approach? Where you drain the cyst and just resect the safe resection of the capsularum.
In my opinion, you can use any of the approaches. Every is okay for this. You can use pterional, basal interhemispheric, transcallosal. But going further, we chose the transsphenoidal approach in this case.
I missed how old the child was.
The child was 10 years old.
Okay, because it is still a pre-cellar sphenoid sinus. It is possible. Just to the lamina terminalis approach data, it's very difficult to get as high as this cyst is.
Yeah, but you can see here
very nice.
that the tumor was removed completely.
Beautiful.
But unfortunately, hypothalamus is not seen here. Yeah. So he was suffering endocrinopathy and diabetes insipidus. Until now, there is no any regrowth of the tumor. However, endocrine deficits are stable and they are causing diminished quality of life.
Yeah.
Okay. So can we go to the next case?
Sure,
yeah.
Sure. Is he having problem with the weight, Professor Mandera?
Sorry?
Does he have a problem with the weight? Is he eating a lot?
No, it's okay.
No. Okay. So that's fine. Okay, good. Thanks. Yep. You can go to the next case, yes, please.
Right, so let's go. And this is 14-year-old girl with the tumor like this. So I'm showing only this scan, but it's for sure grade 2 craniopharyngioma, partially cystic, partially solid with a lot of calcification in this tumor. So again, the question for the optimal strategy of treatment.
Shall we start with Dr. Boop? Dr. Boop.
Yeah, these are challenging tumors. I wish I had a patent answer for you. for me, this would be probably subtotally resected and focal radiation to the residual.
Professor Mazumdar?
Please turn on microphone.
I would also go for a safe subtotal resection. And what my approach usually I take is either I'm very familiar with the terional or the subfrontal approach. So I would resect it as safely as possible, because the dreaded the hypothalamus and the stalk we cannot afford to sacrifice, because there is very little we can do as far as the hormonal status in the post-operative period. So I would do a safe radical excision and radiotherapy.
Yeah.
And Professor Grottenhuis?
Well, if I see that correctly, I see the chiasm in front of the tumor, so this should be subdiaphragmatic. Well, this is, in 14 years, this is probably what I would do endoscopic transsphenoidal. Yes, because with the solar part, yeah, that would go. And I'm sure I'm not sure that a total excision would be possible, and then would accept that. And then follow with irradiation afterwards.
Would you try, if there's a residue, would you try another approach to get at that?
No, probably not. No. I would give my best. I do my best in the first attempt.
Okay.
Yeah.
Okay, so we decided. Sorry, just a moment. We decided that the first step, terional frontolateral approach, is the most frequently used by us approach. And here is a movie. So we here frontal lobe, and we went through the lamina terminalis. And our goal was partial removal of the tumor. So here is the tumor here. The cyst opened. We removed part of the tumor through the lamina terminalis. We tried to remove also anteriorly to the optic chiasm, but it was absolutely prefixed, so it was impossible to remove it this way. So then we went between the optic nerve and carotid artery, and laterally to the carotid artery. In every of the spaces the tumor was available. Okay, and then we combine the approaches, pushing the tumor from the lateral side and remove part of it through the lamina terminalis. Okay, and this is the post-operative MRI. So unfortunately, quite large part of the tumor, especially in the third ventricle, was still seen. So what should be the next step? Radiotherapy or second surgery or anything else? Could I have your opinion, please?
When I start, I would say the part that you couldn't remove is actually the part that I would get first with the transsphenoidal approach, because I saw that this chiasm was very in front of the tumor, and then, but you could easily now say, well, go for a transsphenoidal, and then you have another chance. I would still, in this case, I probably would accept this result and then do radiotherapy.
Why wouldn't you do a transsphenoidal now, Prof?
Well, because it is doubtful that you really then have a really total, I mean, oncological total removal, and the risk of recurrence is still there. If it would be, let's say, 5 or 6 years old, I would probably follow it up and try later on do a second approach. She's 14. And I think there would be, if there is no further severe endocrinopathy, because this approach to transfemoidally certainly would jeopardize her, if there is any stalk, it would jeopardize that, absolutely.
It's important, she had no endocrine deficits.
I mean, this is so important, don't underestimate that. We can substitute a lot, but it is never, ever the normal situation. So if you still have a good endocrinological function, I know with radiotherapy over years, it will also go down, but it is more gradual, and they are older then. So to be honest, even if I would now go transfemoidally, I would probably not save her stalk, because it is behind. It is very pragmatic. That is in the posterior part. You see it very late on. So this would be more difficult.
Professor Andres Servio is here. Professor Servio, do you have any thoughts? Servio, okay. If you can unmute Dr. Servio. Okay. Dr. Boop, do you have anything? Would you agree with the assessment from Dr. Grottenhuis, or do you have anything to add, Dr. Boop?
The only comment I'll make is a paper that Aaron Keena published a decade ago, looking at the number of interventions in these children versus their quality of life and their functional outcome. And if you think of each surgery as a major intervention, if you think of focal radiation as a major intervention, then the children who have a single intervention do best. The children who have 2 or 3 or 4 or 5 procedures get progressively less functional. Mm-hmm. So when you look at Andy Parsa's review of 8,000 cranios, a quarter of them had surgery and were just observed, which means if you observe them until it grows back and then you do a second operation and can't get it out and then you do radiation, that's 3 interventions. And your chance of having a very functional child after 3 interventions is not very good. So trying to limit the number of procedures that these children go through, I think, is important from the beginning.
Thank you.
Yeah,
so you propose to use radiotherapy then, yeah?
Yes.
Mm-hmm.
Yeah.
Mm-hmm. Same here. Yeah.
Yeah.
In terms of radiotherapy, is it conventional radiotherapy or proton? Proton beam therapy.
Are you talking to me? No.
Yes, Dr. Boop. In St. Jude, you guys would give proton?
Yeah, so radiation therapy has gotten better over the decades, just like microsurgery has. And it's also important to understand that our expectations have changed over the decades. You know, in the 50s and 60s, all we cared about was whether the children lived or died, morbidity and mortality. And then in the 80s and 90s, we used gross measures like the Glasgow outcome scale, excellent, good, fair, poor. And if a child went to school, then that was a good outcome, even though you talk to the parents and they say, he used to be a straight A student, now he's in special education and struggling to make a D. He went to school, so that was a good outcome. In the current era, we're looking at detailed neuropsychometrics, we're looking at quality of life studies. It's a completely different expectation for ourselves and for the patients than what we've had before. So current proton beam with the pencil beam, 5 millimeters surrounding the tumor is treated. At our institution, we update the registration weekly so that if the cyst or the solid tumor changes size in the midst of treatment, we compensate for that. And we've got pretty good data right now that the kids that have proton beam have better detailed psychometric function than the kids who had 3D conformal. I'll tell you that Tom Merchant just submitted 3 papers on our prospective RT1 study, which is 101 children treated with 3D conformal radiation. And he's now got 15-year outcome on those children with no kids lost to follow-up. So hopefully those papers will be out in the next couple of months. But detailed endocrine, vision, quality of life, neuropsychometrics, a level of detail that we've never had before for craniopharyngioma patients.
Wow, I look forward to those papers. Thank you very much, Dr. Wu. Dr. Mandera. Yep.
Yeah, unfortunately we took another decision about second look surgery, and this time we went to the tumor by transcallosal interferonical approach. And the aim of the surgery was to remove the part of the tumor from the third ventricle. For us, this remnant of the tumor was too large to leave it only for radiosurgery. So we tried to remove as much as possible from the third ventricle, but not from the hypothalamus to preserve the hypothalamic function. And this is the part of the procedure. So we removed a lot of calcified tumor from the third ventricle and the part of the solid part of the tumor as well. Okay. And this is the last part of the tumor in the anterior edge of the third ventricle. However, we left the part here. And this is a post-operative MRI. So the callosotomy, the third ventricle now is empty with no tumor seen. And we left only the part of the tumor here in the hypothalamus, and then radiotherapy was used, and this is MRI 2 years after radiotherapy. So the remnant of the tumor is still reduced comparing to the pre-radiotherapy picture, and the child is now, it was in 2013, so till today she is without progression of the tumor and without significant endocrine deficits.
That's very good. Excellent.
So I don't know if it was good decision, but I think in such cases there is no one the best decision. I don't know if you agree with me. But
it was beautiful surgery, I'll say that.
Yeah, you have to really do it case by case, Merrick. That's what you're showing in these cases. There is no standard or anything possible. But you have to decide on the case base. Yeah.
Individually for nearly every patient, with some main aims of. Okay, and the next case is a little bit different because it's also for sure a grade 2 tumor, but it is a 3-year-old girl, so small type, and she was admitted due to symptoms of increased ICP due to hydrocephalus. She was at admission blind in her left eye with normal vision in the right eye, and she was not previously diagnosed endocrinologically. So it was in May 2001, she was shunted because of acute hydrocephalus, and tumor was removed by fronto-basal interhemispheric approach. And in the next MRI, it is September 2010, it was seen small remnant on the tumor here seen, so just posteriorly to the optic chiasm. 3-year-old child. What would you recommend? Observation or radiotherapy? The child is 3-year-old, or second surgery, or anything else?
Professor Gordon Hughes.
Oh, I would, at this moment, I probably would follow her up with the scan and see how this will develop. Because this is the first post-op MRI that you have?
Yes, moment, I check it. It was my.
It was May, yes.
It was immediately after surgery MRI.
Yeah,
it was like this, and this is in September, so 5 months later.
Well, and I mean, this is, you shunted the hydrocephalus. I probably would have chosen a transventricular approach, going into the long axis of the tumor, to try to get it. But of course, remnant is always a possibility. But in this case, I would say she's 3 years old. I would follow this up. Certainly no radiotherapy at this time. I would try to postpone this as long as possible.
Okay, so let's next. We did it. We observed it, and this is next MRI, January 2011. So it was October, no, September. It's January, so 3 months later. And the tumor seems to be a little bit larger with small cystic part. Yes.
Certainly growing, yeah.
Still observing or trying to do something?
If you want to do something, you want to get this, you want to really get it out completely, and that will be tough. Second case, and what Dr. Boop said, it is you want to have the least amount of procedures over the lifetime of such a child. And if she's not symptomatic, but to be honest, it's September to January, and you see already the cystic part growing now. Tough decision. Probably
make a decision more difficult. The father of the child is neurosurgeon.
Aha.
Really?
Well, I don't know if, well, you can, well, maybe that's even easier. You can ask him for the father for a decision and say,
Not
what
pediatric.
you do, what you do. No, of course you cannot, because it is his child. No, but
yeah, completely different thinking. Yeah.
Yes. No, you would absolutely be not, and no possibility to make decisions in such a situation. I'm just thinking about what type of procedure would be best here. The first one was a basal procedure, and I would not love to go through that same direction. You saw already basally there is some frontal encephalomalacia, so that would probably be then more a pterional approach through the lamina terminalis to try to get this out. Yes.
Aaron? Yeah.
Yeah.
Anyone else wants to make any comments? Professor Mazumdar?
Yeah, I was also thinking on the same lines. It is a very tough decision. But I would agree with Professor Gordenius. I would go from a virgin area, and from the pterional maybe decompress the cysts and have a look at the solid component. If it is we are able to remove that, that's fine. But if it is too stuck or something, I would just reconsider and then see what about adjuvant therapy. But certainly decompress that cyst and take out the solid component as far as possible.
in our opinion, further observation was not good way, as it was growing and the child was young. So we decided to operate it again by the same basal interhemispheric approach. Optic chiasm left, radiation, and the tumor. The problem which we met was that she was blind on the left eye, and she had quite good vision on the right side. So here it was no problem to remove this part of the tumor. But just a moment, it will be seen the small part of the tumor on the right optic radiation. Just here. And we were very afraid to remove it, not to cause the blindness of the right eye. So we left this small part of the tumor, and this is post-operative MRI. So such a small remnant still is possible to see. But in this moment, she was already four, a little bit more year old. So we decided about radiotherapy in this moment, and this is MRI after radiotherapy. So it was in 2013, so 2 years after this surgery, and there is only very small remnant of the tumor here. And as I know, she is free of progression till today. She's living in a different city, so I don't have the follow-up from the last 2 years, but I think it was okay till 2020.
It's very often the radiotherapy is rather a focal conformal radiotherapy, but I looked up in my own cases and that of a colleague in one of the other university medical centers, and in those patients even treated for craniopharyngioma, we had 7 cases that had meningiomas after 20 years.
Oh, wow.
Yeah, there was quite a number. I was so surprised. Small ones, but you have to follow them very hard. I mean, this child is 4 or 5 then at that time.
Yeah.
Then in 20 years, 25 years.
She was 4 when she was irradiated, yeah.
Yeah, but you have to, we actually have, we have a special clinic called Later. It's in the same in Dutch, later. In that clinic, we see all the kids that have been irradiated, either for leukemia or for, it's also for brain tumors, medulloblastomas, craniopharyngiomas. And we were surprised if you do this long enough, you have to do it very long, because often these children, when they are 18, they say, that's fine, it looks all good. But you have to follow those kids more or less forever. And because many of these meningiomas are not single, but multiple meningiomas. Typically, for the craniopharyngioma, it's falx, and parasagittal. And the medulloblastomas, they have more the convexity meningiomas.
Okay. And Naren, can I show one case more? Or?
Absolutely, yeah.
Yeah, fine. So everything is nice with radiotherapy, and I agree absolutely it is okay. But what to do if we have relapse after radiotherapy? Pouget, she wrote in her paper in 2007 that the only available treatment option for post-irradiation recurrences is surgery, and surgery at this stage is technically difficult and can result in morbidity at levels currently seen with gross total resection. And I must say, I absolutely agree with it. And I would like to show you one case more. I'd like to illustrate this with a very bad case of an 8-year-old boy who was initially treated surgically in a different center, and the tumor was partially removed. In follow-up, MRI remnant of the tumor, but only intracellular was seen here. Yeah. However, the decision was then radiotherapy, and he was irradiated. Stereotactic radiosurgery was used. He obtained 15 gray, and 2 years later, the regrowth of the tumor, mainly cystic one, was seen. It was then, and 4 months later, it was yet bigger with a solid part. So in 2009, he was operated again, and the tumor was subtotally removed by right pterional approach. And the surgery was very difficult due to very dense and tough scar formations in the region of cisterns and pericellular region. Of course, probably caused, or by sure caused by prior radiotherapy, which made surgery very, very difficult. Again, it was only partial removal. So, look, it was July 2009, and in December 2009, it was such a big regrowth of the tumor, and next 6 months later, in May 2010, yet bigger tumor, further growth of the tumor and hydrocephalus. During the next years, it's September 2010, so next 5 years. And next surgical procedures already done by us, so again, subtotal removal by right pterional approach, and then left pterional approach, and then partial removal by transcallosal interferonical approach, VP shunt implantation due to hydrocephalus, implantation of Ommaya reservoir to the cyst, and unfortunately, 5 years after diagnosis, this child died due to such a huge progression of the tumor.
It looks like a malignant transformation.
Unfortunately, he died and he had no autopsy examination, so we don't know. It looked like a malignization.
Yeah, it is a kind of, even if there's no proof already from that initial.
And it was after radiotherapy.
Yeah.
It was stable for
Wow.
quite a long time. And after radiotherapy, it started to grow very, very quickly.
Well, this kind of explosion.
Right.
Yeah.
So the question we asked to us were, what was wrong? As I think, for sure, insufficient first surgery. There was no hypothalamus involvement, so tumor should have been totally removed during the first surgery before radiotherapy. Yeah? Next, ineffective and maybe inadequate radiotherapy. She was stereotactically irradiated with total dose of 15 gray, and difficult and ineffective next surgeries due to very dense and tough scar formations in the region of the cisterns and pericellular region, probably caused by radiotherapy. But this idea of malignization was also my idea. However, we have no evidences for that. So this is really very sad case, and this question about radiotherapy, what to do when we have some patients with progression and regrowth of the tumor after radiotherapy, and in every such a patient, the next surgery is very, very difficult.
The pathology report of the first surgery, did you find something unusual, or it was just craniopharyngioma?
No, craniopharyngioma.
Just
only craniopharyngioma without any other tissues or something like this.
Have you seen a similar, quite quick expansion, Professor Mazumdar, in your practice?
Yes. I've seen. That's why the Professor Grotten has correctly mentioned malignant craniopharyngioma. I have one patient which was operated 36 times. 36 times. So he from the childhood he had so many these things, and ultimately he died. He died as a young man. So
It is difficult. It is
very
difficult to prove this histologically.
Yes.
If you ask your pathologist, it is still craniopharyngioma.
Craniopharyngioma.
We even had a case with dissemination. So we had distant lesions, and we had an autopsy. It also died, and it still was histologically, it was a craniopharyngioma. And that's so it is difficult. Not even, let's say the MIP index was somewhat higher, was 6%. So this is maybe higher than you would expect in a standard craniopharyngioma, but the pathologist never really could say this is a clear malignant tumor now. So, but I mean, clinically, this is malignancy.
Malignant, yes.
Yes.
I agree. Yes, absolutely.
But do you think that this explosion of the tumor and this probably malignization was connected to radiotherapy, or it was just because it was such a tumor?
It's difficult to have any proof.
Answer.
We sometimes see that, and people reported from irradiation of schwannomas, and that you see a vestibular schwannomas, and then you see explosion of that tumor, rapid growth. Is it radiotherapy? We don't know. But on the other hand, we expose a lot of these children to radiotherapy, and you don't see this very often. These are still case reports. They are still.
We do see many cyst expansion, right? We see single or multiple cysts after radiotherapy, but not this kind of an appearance. This is surely something genetic, probably. I don't know. Something.
Yeah. What an awful case. Yeah. Wow. Terrible. Gee.
Okay. So Naren, these were all of my cases, and I think it's difficult to clearly answer what to have any consensus on craniopharyngioma treatment. I think, as it was already said, that in every patient, individualized approach should be overtaken, and the decision has to be done in every patient individual. Yeah.
Sure. Thanks. Thank you very much, Professor Mandera, for that very illustrative and cases that we could which show the difficulty in decision making and all the options. I've got some controversial things to ask the panel. In terms of when someone is excising a craniopharyngioma, it's always attempting to take as much as tumor, and but most of the injuries, as I understand, is from traction on the hypothalamus. At what point do you say it's time to stop, Professor Grotten-Hughes?
Naren, this is a very tough question to answer, because this is such a decision is based on your own experience. It's how you learn how to deal with tissue, how to recognize a plane of cleavage, maybe how to create a plane, and that's not so easy to do. The same is how much can you start dissecting the cyst wall from an optic nerve. It depends on not doing too much, but you want to get it off. It's very individual, and I think that they say when an experienced neurosurgeon just have made more mistakes than a non-experienced neurosurgeon. You learn from your mistakes. Initially, I'm sure in end of the 80s, early 90s, I attempted. I did my pediatric neurosurgery with Harold Hoffman. You probably don't know him anymore from Toronto, but he was famous for his complete removal of craniopharyngiomas. I tried to also do that, but if I look to those series, these all were afterwards obese children, short of stature, with their irradiation that they still needed because of recurrences, and they never could finish school. So, my goodness, I often told myself, well, you did a lot of damage to them. The same in trying to remove schwannomas radically. I had much more facial palsies than in later years of life as a neurosurgeon. So the difficulty is it is not the risk for the surgeon, it's the risk for the patient that you have to put them through. And you call the hypothalamus, I started to have a lot of respect for that structure. Really, I go through the lamina terminalis. I don't want to go to both lateral sides very extensively. If you go from one side, pterional, and the lower side, then you don't see a lot because you don't really see I often say the moment you already, after resection, see the mammillary bodies, you probably already have damaged them. So this is not an easy thing. It is an intraoperative. I tell the parents and I tell the patients, it is an intraoperative decision that I have to make. I never can see on an MRI scan if it will end up being a gross total removal or just a subtotal. It's always an intraoperative judgment that you have to make.
And it comes with the experience as well.
Yes.
Yeah, well, but I say the experience, you gain experience from the failures that you have and the mistakes and let's say the bad outcomes you have created as a surgeon.
Thank you.
Absolutely agree, Dr. Kurtenis. Absolutely. You have said it the right way.
Thanks. Professor Mandara, do you have anything further to add on that? Thanks. You need to unmute Professor Mandara.
I'm always telling the neurosurgeons in training that there are 3 stages of learning craniopharyngioma surgery. First stage, when you are very unexperienced and you try to remove as much as possible of the tumor, but you cannot, you are not able to do that. And then you say, okay, I left some of the tumor because there is such a recommendation and so on. Later, when you are more and more experienced, you can remove the tumor, and then you do it usually with endocrine deficit then. And the third stage is that you can remove totally the tumor, but you don't do it because you will know that the better way is to preserve the hypothalamus function and you leave some part of the tumor. Also, you can remove it, but you don't do it for the better quality of life of the patient. I think it is the highest level of craniopharyngioma surgery.
Agree.
That's great. Thanks. Another question, Dr. Boop. I'll start with Dr. Boop in this one. In terms of how many cases one needs to do to be the case volume per year, because in Britain there has always been a last 5 years or so many years a controversy whether it should be centralized or not centralized. Should it be done by a pediatric neurosurgeon in one big or two big centers, or adults neurosurgeons who go into this area often, whether they can do it with pediatric neurosurgeons in our regional centers. Do you have any thoughts, Prof. Dr. Boop, on what's the case volume you need to be to keep the hands warm in this or the mind warm in these cases?
Yeah. Well, if you look at the numbers, the average children's hospital sees 30 to 40 brain tumors per year. And craniopharyngiomas make up 1 to 2% of our pediatric tumors. So that means the average pediatric neurosurgeon will see 1 craniopharyngioma every 3 years. And if you do 3 in a decade, I don't think you can ever be good at it. And I think if a young neurosurgeon wants to do a craniopharyngoma, they should do it with an experienced senior neurosurgeon, not do it by themselves. And then I think, even for me, if I have a craniopharyngoma that I think needs approached transphenoidally, I'll send it to my skull-based partners who do 3 or 4 pituitaries a week and are very good at that approach. I won't do it myself. So I think when a child presents with a first-time craniopharyngoma, then the neurosurgeon should approach the child with curative intent, but have a low threshold to back out and let radiation therapy have a chance. I think if they're a recurrent tumor after radiation therapy, then the neurosurgeon's only choice is to try to get the tumor out if at all possible. Because if they don't, it will grow back and we don't have any other options except more surgery.
Thanks. Thank you very much. Dr. Pope, Professor Gotthardus, you were agreeing?
Yeah, I certainly agree. As we say, we deal with a lot of rare diseases. They are not frequent, and I think centralization is useful. You probably know since a couple of years, we have centralized all pediatric oncology in one single center in the whole country. So there is one center for 17 million people, so they have a sufficient number. They see about 140 brain tumors every year. And then you can, you gain experience. And that is, I think it is wise to do that. But we discussed also yesterday with colloid cysts. I mean, they are rare. That was centralized. I did them all from the Netherlands, but that means 9 or 10 cases on a year basis. So in my whole career of 30 years doing it endoscopically, I had exactly 91 cases, 30 years.
Wow.
91 cases. I mean, these are rare diseases. So this is simply, it's very, very hard to call yourself experienced. But I have to say, it's not only about craniopharyngoma. Dr. Boop said, if you want to have a transphenoidal approach, ask your pituitary colleagues doing that, because they do this on a regular basis. And for example, pituitaries, I did about 80 a year. So then that approach is much more known to you. And I think dissecting an extracerebral lesion is a certain type of microsurgical technique that you will develop also out of other types of surgery that you can do. Also dealing with the vessels around it. I mean, if you do also vascular surgery, you learn how to deal with that. And if you do schwannomas, it's not the same as a craniopharyngiomas, but it is the way of dissecting neural tissue. If you get that schwannoma at one point from the brainstem, how you get that arachnoid sheet off of the schwannoma and keep that intact from the brainstem, all these things that you learn in other types will also help you in dealing with craniopharyngioma. So it is not SEC the only case, of course. Nevertheless, I fully agree that, I sometimes heard a doctor saying, even if they only did one pituitary adenoma in 3 or 4 years, they say, but I like that surgery. Then I often respond, it is not what you like to do, it is actually what the patient needs to have. And that's the best type of surgery. You would not want to be operated by a surgeon who only has done this once in 4 years. That we have to be honest to that. It is not about what we like to do. It is what our patient needs. And therefore, I think that's the background of concentration. We should be frank in that, and then and really send it to a region where we really say, this is a sufficient number to get good results.
I think that that really I think it's always easy for surgeons to become surgeon-centric, particularly with this demanding surgery where you want to show a nice scan and prove yourself.
Right.
But
It is,
but I think it's always important, absolutely important, to keep patient in mind. And as you said, I have seen people who like craniopharyngioma surgery. The minute it comes, they are so excited to get their hands on it before someone says, don't do this or don't do that. And but I think the patient comes first. There's one more question, is that I don't do surgery for craniopharyngiomas, but when I'm on call, I have to look after them. And the endocrine aspect of it, I find the post-operative course is so stormy that if you don't have a very good endocrine service to back you up, I mean, it's like watching a ship that's just drifting towards the rock. And how much, in terms of Professor Mandara, do you have a whole 7-week cover of endocrinology, or you don't have any endocrinology over the weekend? How does it work?
Yeah, it works very well in our department because, well, in the same hospital, just one level up is the huge department of pediatric endocrinology. And we have two endocrinologists who are really very near cooperating with us. And they are very experienced in treatment of the endocrine deficits, even in the acute postoperative period. So they help us very much. And if the child is suffering diabetes insipidus, and for example, the child is going home, they are always, the parents can call on mobile to these endocrine colleagues and discuss if they should give more or less desmopressin and so on. So it's really the cooperation between neurosurgeons and endocrinologists in the matter of craniopharyngioma is absolutely must. And I cannot imagine the situation that somebody is treating craniopharyngioma without endocrinologist's help. I think it's impossible, because then it can be really catastrophic, especially in the early postoperative period, if hypothalamic symptoms are really very distinct.
Thank you. I think many people who don't, many in the audience like me, who haven't seen so many craniopharyngioma patients, the first time you come across a patient who has hyperphagia, and it really can be pretty devastating. I worked in the department. I inherited a patient who was just ballooning by the week or the day. Have you had any hyperphagic patients, Professor Mandara? And how did you manage those patients? Did they have any functional neurosurgery, or
what do you mean?
Hyperphagia, they eat a lot.
Yeah, sure. It's a big problem. I think the biggest problem in the patient, especially who are treated by total resection of the craniopharyngioma. And sometimes these are really dramatic situations. Sometimes they are funny, because I have two patients who are already adult. Both of them are cookers, because they want to be very near any food. Yeah. But there are also children who are really terribly obese, and with suicide attempts because they cannot accept themselves and so on. And this is really endocrinologists who try to fight with it, but it's really the problem. And I think that is no problem with hypothyroidism, or that they have to get some cortisol or something like this. The problem is with obesity. And this is the factor which reduces the quality of life in the bigger scale. I would like it to go back to this role of endocrinologists, that in postoperative period, in nearly every patient, there is a time of diabetes insipidus, and then it's going from the diabetes insipidus into hypersecretion of vasopressin. Yeah. So it is very, very important to be very careful about that, and not to do it just the child is going by himself. It's necessary to know when to reduce the desmopressin, when to add it, and so on. So I cannot imagine that neurosurgeons by themselves can treat such children.
No.
But endocrinologists have to help in it.
There's one thing that is very often overlooked, or not that they are not aware of, especially in those children who have hypothalamic damage and become obese. They often also have polychlorothermia. And this is something that not a lot of people are aware of. I saw a few kids that during a hot summer day, they were outside and playing, or were sent into the hospital comatose with a very high temperature. And during the winter, they have hypothermia. So this is called polychlorothermia. They simply don't have a thermostat anymore. So they can't adapt. They can't keep the normal temperature. That's also an extremely cumbersome situation to handle for the patient.
And when you had patients with hyperphagia, was there what was the treatment, Prof. Cortenius?
Well, the only for the hyperphagia, so really this overeating, and actually they sometimes as a kids they cry and say, "Mama, I haven't had anything to eat," although they just finished the dinner. They also don't remember that. So it is extremely difficult. It can only be handled by strict control of the calorie intake. And they never can do it themselves. So they always need supervision. And that the same is with this, because the polychlorothermia has that. And actually we had a short solution for the problem with the temperature. They got a whole suit that comes from the military, where they when they are in the desert they are cooled. When they are in the snow they are warmed up. That's so-called Pelletier element in it. So they wear that, and we placed a sensor in the ear, checking the temperature. So when the temperature was going down, they were heated up. And when the temperature was going up, this element this suit that they were wearing were cooling them down. But that's still not so easy to manage. We never found something for the obesity, for the control of food. But the other one with the temperature was this little. Well, the technical university developed that system, and that was a kind of makeshift for them.
Thanks, thank you. Dr. Boop, do you guys have does your team have any sort of solution for hyperphagia?
No, we've tried a number of different medications on protocols and not found any medicine that works. Even bariatric surgery, they're able to find ways to overeat with bariatric surgery. So I don't know a solution to this problem, except to try to avoid it when you can.
Thanks. And the avoidance is basically trying to minimize as far as possible hypothalamic damage in the vague world. That's brilliant. Thank you very much to Professor Mandera for these excellent cases. Trying to get get a handle on craniopharyngioma is difficult because the cases are varied and the options are many and the surgeon's preferences are different, and it's a multidisciplinary decision. and at the same time, the constellation of problems are also many, and it's probably one of the areas that a molecular treatment will end the misery for patient and the surgeon. I hope. Dr. Boop, is there anything molecular coming up on the pipeline as far as you know for these craniopharyngiomas?
Well, you know, for the adult craniopharyngiomas, there's an ongoing trial with BRAF inhibitors that is showing some promise. I don't know the results of the trial yet, but there are anecdotal cases reported of dramatic and quick responses. There's a single case report by Jeff Wissoff and Jeff Allen at New York University of a child with an adamantinomatous craniopharyngioma that they treated with a monoclonal antibody and showed a response. So that paper is in the literature, but it's just a case report.
Thanks. Thank you very much. Now that you mentioned Dr. Wissoff, we got a lecture from Dr. Wissoff on craniopharyngioma about 6 months ago. And on the introduction, he said his father was a neurosurgeon, and he used to say that you can only say that you are an experienced neurosurgeon after you have operated on a meningioma, and then it comes back after a complete excision, it comes back. Until then, you can't say you are an experienced. And he went through, the definition of when you can claim to be an experienced neurosurgeon. I thought that was really pretty. So thank you very much. So now, thank you very much, Professor Mandra. Thank you all the discussion. So now, which takes us to, I put a poll about intraoperative imagings, and we are going to get Professor Llewellyn Paediatric to set the stage for discussions on this. Thank you.
Thank you, Nan. You can see my slides. And
yes.
Yeah, great. Thanks so much. Again, thanks so much for putting together the cause, and congratulations on all the fantastic work you've put together. You've kind of done putting this together and the people you've invited. So I'm going to talk on the topic you've asked me. So intraoperative imaging, and just unpack it in the actual context that it is. So the modern neurosurgery theater, I think a lot of us would agree, as we've seen from some of these talks, has really evolved tremendously. And as we invite more physiologists and navigation technologists, you realize it's quite an intimidating place to be. And this is really because of the wide array of intraoperative adjuncts that are available, and imaging is just one of those. So I want to make that context very clear. So the things that we sorry, this poll just keeps coming up. And
I took it out.
Okay. So, things are like neuronavigation systems, whether they're frame-based or frameless, minimally invasive techniques, microsurgery, neuroendoscopy, the endovascular techniques, and novel ablation techniques, and then intraoperative imaging, which is very much a structural type of adjunct. What has been described there have been things like the intraoperative MRI, the intraoperative CT, intraoperative ultrasound, which I've developed some experience with now, and I'll talk about groups and causes that have been run, just trying to promote this as a more usable adjunct. And then fluorescence guidance, which probably falls under this group, but kind of slightly less clearly image guided and more sort of fluorescence guided. And then your functional operative adjunct, cortical mapping, and intraoperative neurophysiological monitoring. And I just want to make the point that a lot of times, at least in our practice, and I think in the practice of a lot of the eminent surgeons involved here, there would be an overlap between those. So one would use imaging together with monitoring techniques. It's never really an either or type of scenario. So just a picture of some of the things I've mentioned now: navigation, imaging, 5-ALA, and then the monitoring. For completeness, I've put this fluorescence guided surgery on, but it's not sort of a fundamental part of the talk, just in an effort to make it more complete. So ultimately, as neurosurgeons, and this is really maybe well positioned from some of the previous talks, we often gauge ourselves, and depending on the amount of experience you have and how you define experience, as we've heard, estimating the extent of resection is an important facet of determining whether you've done a good job or not in the post-operative imaging. And there's a huge discordance between the surgeon's impression and the actual degree of resection. And oftentimes, or more often than not, there's more tumor left behind than we think. And this is, generally an inadvertent residual tumor. And it's in this context that things like real-time imaging, depending on how you actually define that, but intraoperative MRI and ultrasound are perhaps more useful in bringing this discordance between our impression and what we actually do closer together. Again, the other adjunct that I think would be used almost consistently with some kind of intraoperative imaging is navigation. And with larger tumors, I think its role has really been limited to preparing and planning your craniotomy and your durotomy and your initial sort of resection technique, and then augmenting this with some form of intraoperative imaging. This is the case I like to show. Yeah, 8-year-old kid with quite a large supratentorial tumor that we resected, and at the time didn't have any sort of intraoperative imaging, so no intraoperative ultrasound. Thought we did a pretty good job, resected it, and the immediate imaging we got was an uncontrasted scan for reasons which were quite odd, but it looked like a good resection. But if you look carefully, you can see, something that looks like residual there, which I couldn't actually see at the time of resection. So, I left what I wasn't sure about. And then a scan done about 3 months later showed that there was what we call recurrence, but may actually have been, more residual tumor than I thought, and with some recurrence. So this I think maybe illustrates the point quite well, that if I had a tool like an intraoperative ultrasound or MRI for that matter, we may have picked this up and may have been able to resect that more completely. So in this gambit of what type of intraoperative imaging one would use in brain tumor surgery, it's really a contest between MRI scan and intraoperative ultrasound. The intraoperative CT scan has gained quite a bit of traction, and I've seen a bit more published. And some who use this have reported good results. I've got no experience with that, so it would be good to hear from some of the other audience members who actually has some experience with that. So just shortly, then I don't want to belabor this too much, but the intraoperative MRI into neurosurgery was introduced around about 1994, and the aim was to increase the accuracy, the safety of neurosurgical procedures, to look at frequent intraoperative imaging updates would address issues like brain shift, volume of residual tumor, and then even whether a hematoma was present. It's quite reassuring before one closes up and sends the patient out to the critical care unit or back to the ward. The range of these tools ranges from 0.2 to the high field 1.5, and these impact significantly on image quality and acquisition time. And then useful adjuncts, things like MR angiography, MR tractography, and spectroscopy can, or at least have been reported in some of these. I think particularly the MR angiography intraoperatively is quite a useful adjunct. The benefits reported are things like increased rate of complete resection, where the surgical strategy was actually modified depending on the imaging. That's in up to a third of reported cases. It's very important that in this particular context, probably more than any other, that there's a good collaboration between the neurosurgeon and the radiologist performing the imaging. I included this study from Israel just to show that the value of intraoperative MRI scan is not just in the context of brain tumors. In the small group of patients, the Israeli group showed that combining navigation with intraoperative MRI was very helpful in redefining targets for fenestration. This was in an endoscopic series of patients with multiloculated hydrocephalus, and they found it accurately helped in terms of documenting brain and CSF shift. And the combination of these two, navigation and intraoperative MRI at the time, in their opinion, was a really useful one. So despite all its appeal and the fact that often big centers or research centers define themselves by whether they have an intraoperative MRI, there are very clear limitations. And those limitations relate to the huge infrastructural setup that's required, the manpower. The setup costs are incredibly high, and that is probably the biggest limiting factor. So it's still an imaging modality that's limited to, like I said, really research facilities or esoteric facilities that have funding for this sort of infrastructure. The ongoing maintenance costs and staffing costs are additional to the initial setup costs. The acquisition times are quite long, and the logistic involved in getting these imaging is still a big limitation. And like I said, the limited availability really because of all of these, the above mentioned things. So in that context, Intraoperative ultrasound, by contrast, is a lot cheaper. It's a lot more accessible. And I think from your poll earlier, Naren, I just saw it flash on the screen, virtually everyone has, in one way or another, an ultrasound machine that may or may not be usable, but at least for this context, but at least is an option to try and implement. And it's in that context that we've driven this quite hard. And I'll show, there's some courses that we've developed now and try to teach, people. The initial learning curve for neurosurgeons is quite steep, but after that, becomes quite an easy tool to implement. Some of the history, I'm going to skip over that in the interest of time, but just of note, Carl Dussek was the first physician to actually describe the use of ultrasound, and he used it in a patient that he thought had a brain tumor, and you can see what he thought were ventricles here. Turns out he was wrong at the time, but certainly the first description was of trying to define a brain tumor. So the use of ultrasound in neurosurgery, I'm just going to mention this briefly as well. I think it has, as a modality, more use in our field probably than any other modality. So whether you use it diagnostically to determine ventricle size, raised ICP, things like transcranial Doppler or optic nerve sheath diameter measurement, craniosynostosis, to increasingly there are more reports on using ultrasound to define the actual absence or presence of the suture. Peripheral nerve surgery is a very rapidly developing indication. Intraoperative navigation, which is the context I'm talking about now. So tumors, VP shunt insertion, guiding of endoscopic fenestrations in multiloculated hydrocephalus, PRE1 malformation is a sort of quality check for how far one decompresses, and then vascular and peripheral nerve. And the same technology is also present in our CUSAs and piezo surgery. So they're all ultrasonic aspirators based on ultrasound technology. Then advanced therapeutic techniques, things like high intensity focused ultrasound, again, getting a lot of traction in tumor management and functional surgery and disrupting the blood-brain barrier, and then things like neuromodulation. So historically, they were first described in the A mode context, and again, I've included this really just for completeness, and then advanced in the 80s and 90s to B mode, where one could actually see images that correlated to what was seen on the CT or MRI scan. And in this context, neurosurgeons started to describe the use of it more, just because of how intuitive it was to use, but it's quite to the contrary, how counterintuitive the imaging planes were. So they're not the normal sagittal, coronal, and axial planes that we're used to, but if you can get over that, the advances were quite profound. So the group in Trondheim, led by German Ungsgaard at the time, probably even, I think, up to date, have published more than anyone else on the combination of what they call 3D ultrasound, where the ultrasound technology was combined with preoperative navigation and then interfaced onto MRI scans in an effort to give you a template from your preoperative MRI scan so you could see how much tumor was removed during the surgery. And this came with significant benefits, but also significant limitations. The company ultimately, unfortunately, because it was developed by Syntef, which is a research organization, went bankrupt just because of poor sort of commercial planning. But the actual technology, and this is from all who've used the technology, always spoke very highly of it. So in my practice, like I said, I use it for ventricular catheter placements. Increasingly now, every tumor resection, I'll use the ultrasound, endoscopic fenestration and catheter placement, especially in complex multiloculated hydrocephalus, for vascular procedures, Chiari malformation decompressions, and intermedullary spinal cord tumors. So I'll show some of these images, but before I do that, just quickly, so what does one need for ultrasound usage? So you need an adequate dual window. Surgical window could be the fontanelle or craniotomy. Craniotomy or fontanelle. I'll do it the other way around, depending on what you actually want to use the ultrasound for. But definitely for tumor surgery, obviously one needs a craniotomy. The procedure in which you sterilize the equipment and the protocol you use to follow determine the image quality, particularly the spatial resolution, which is determined by the probe frequency and size. So obviously it can't be too bulky, but needs to give you good quality imaging. And then, like I said previously, one needs to get used to the multiplanar image display. So it's really called orthogonal or dual plane because it's not our traditional axial, sagittal or coronal planes. And then user experience, I think, is probably the most important thing. So the initial user experience is quite steep and uncomfortable. Once you get over that, I think it becomes very intuitive and is one of those tools that the more you use, I think the more one finds indications to use them better. So this image is courtesy of German Ungsgaard, and positioning of patients in terms of how to fill the cavity with the the fluid to optimize imaging quality. And they've also gone on now to develop an acoustic coupling fluid, which I'll show quickly, at the end, really just improves the quality of the imaging. So this is the case of a high-grade glioma. You can see the imaging here. So that's what it looks like on ultrasound. And I've particularly shown this so you can see some of the limitations as well. At the superficial end, the imaging is good. You can see the midline, the ventricle on the other side. And as you get lower down, the imaging quality tends to become a little poorer. And that is a limitation, but one tends to be able to get around that with more frequent use. In addition to that, the Doppler feature shows you the vessel outline, which is really, really helpful in terms of its real-time feedback. So this is that same case. And I've shown particularly these images because it can be a little difficult to interpret. So if you compare that to the previous image, you'll see there's a resection margin here, but whether that's residual tumor or not can be difficult to actually interpret if you're not completely comfortable with that. So we remove the tumor, you'll see a bit of fluid in the cavity there. And this was confirmed on post-operative imaging on the ultrasound. So I showed the image here. And again, maybe this is, I've put this image in specifically to show that it can be a little difficult to interpret at the start. This is a kid with a posterior fossa tumor, and you can see here, clearly the imaging correlates a lot better. You can see the ventricles there and the tumor here. So the margins are clear. You can see the tent on either side. And with certain tumors, the localization is a lot easier. This is an intraventricular tumor. You can see how well the intraoperative ultrasound images, compared to the preoperative MRI. This is a kid with a choroid plexus tumor in the lateral and third ventricle, and you can see the quality of imaging really comparable. And additionally, you can see the vessel that's demonstrated here, but you can see how clearly that's demonstrated on the Doppler intraoperatively. So there are very clear benefits once you become more used to using them. The vascular function I found incredibly useful, especially in posterior fossa tumors. So you can see differentiating tumor vessel, which is there, versus your picas here. In this particular case, adjacent vessels. It's always nice to see those vessels, reassuring to see them preserved post-operatively. So when you compare them to the preoperative imaging, the Doppler function is really advanced quite impressively, and I've wanted to show that video just because of that real-time feedback. And depending on whether this is a research project of yours or not, you can actually measure that flow pre and post-operatively depending on what your research output or your plan is. Okay, this is a case I also like showing, so you can see how well the preoperative ultrasound and MRI images. This is intraoperative. Thought we'd got, what was most of the tumor. You can see there's a little bit of hyperechogenic stuff here. We resected that. That's what the image looked like. You can see a nice clear flow of the fourth ventricle all the way to the aqueduct. And it's really always, I think, reassuring and comforting to know that when you close up, you've got these intraoperative ultrasound images to confirm. This is a kid where we knew it left residual because of its attachment to the brainstem. You can see that here. And again, the ultrasound image confirmed that. So we knew more or less what to expect. So when the imaging was done post-operatively, it's always nice to anticipate what that will look like. Again, just to show the quality of images, you can see these are very comparable. So that's an intrafourth ventricular tumor. That's what it looks like here. But often one can get this artifact that is a bit difficult to deal with. That may be related to the anesthetic machine or the diathermy. And really, one's got to figure that out as you go along. But even then, the quality of imaging is really acceptable. The scan I showed earlier, you can see that's what the pre and post-op scan looks like. And you can see the tumor there on ultrasound. And then once it's removed, you can see the mass is completely removed. For spinal tumors as well, I think I may be running a little over time here, Lawrence. I'm going to speed that up. You can see the tumor here. That's what it looks like. Post-op imaging, and you can see the tumor is completely resected with a little bit of collapse of the spinal cord. Again, just to confirm a case with complete resection, always nice to see that clear tumor bed before you close up. What I mentioned briefly previously, I told you about the imaging artifacts. You can see at the end here, even though this tumor was completely removed, it's a little disconcerting to see that hyperechogenicity, and it may be from the PL membrane, it may be from the saline, but there have been developments in acoustic coupling fluid now, and you can see to some degree just changing the quality of the fluid can improve your imaging quality. Study showing intraoperative ultrasound and post-op MRI. Generally, the correlation is really good, but has a sort of learning curve attached to it. So the more used to it you become, the better you are at interpreting the images, the more useful it becomes in terms of its outcome as a determinant. This is a study published by Ali Asghar Moyadi, somebody we've done a lot of work now with using the ultrasound in brain tumors. And you can see when one compares intraoperative MRI to ultrasound, overall, the benefits from intraoperative ultrasound, they appear to match the intraoperative MRI in terms of image quality, but completely improve on it in terms of user interface, cost, and all the things that make a lot of difference, particularly in centers or countries of where resources are not as widely available as others. This is a study I just included this because of the 5-ALA. They looked at comparing intraoperative MRI, 5-ALA, and intraoperative ultrasound in glioblastoma surgery in a way, trying to compare them as a metric, and found that the ultrasound compared very favorably to 5-ALA and intraoperative MRI. Okay, I'm going to skip over this. This is just a study from the Norwegian group as well, where they based all their resections on ultrasound and less even on sort of awake craniotomies, and found that it was really helpful for them. There are certain advantages. I'll just skip through those quickly. So there's contrast enhanced ultrasound, elastography, and then vascular lesions. 3D ultrasound I've shown. The contrast enhanced ultrasound, depending on whether you have this available or not, really is like a contrast enhanced MRI scan. It really makes a massive difference in terms of the quality of imaging. And Francesco Prada has done a lot of work on this and published, I think, probably more than anyone else on this at the moment. Then things like strain measurement and elastography, depending on whether you move the probe or not, would be really useful, I think, more in a research context at the moment than anything else currently. So that brings me to the end of the talk. So I think, in summary, intraoperative imaging in brain tumor surgery is a very valuable structural monitoring adjunct. And I think one needs to bear this in mind. So it should be used in combination with a functional monitoring tool like intraoperative neurophysiological monitoring. And it's not an either or. And I think the more experience one gets with this, the more you realize that they actually work very well hand in hand. So they definitely provide improved tumor safety and tumor resection margins. There's a broad scope of applications in neurosurgery, particularly for ultrasound, so hydrocephalus, endoscopy, hematomas, Chiari malformations. Intraoperative ultrasound is safe, it's cost-effective, portable, diverse applications. So it's not just navigation, but diagnostic and surgical resection as well. I think it's certainly worth making the effort to practically integrate it into our surgical practice. In that note, we've run quite a few courses now, 2 of them coming up, one in Barcelona and one in India, just running through the knobology, as it's called, of ultrasound, so that neurosurgeons can become more comfortable in how they implement this. So thank you very much. I'm happy to take questions as they come.
Thank you very much, Professor Paediatric. I think that was a fantastic overview of the intraoperative imaging and particularly ultrasound. I have worked in departments where we did not have intraoperative MRI and we seldom use intraoperative ultrasound, but we then closed the patient up, took the patient to the MRI around the corner, did the scan, and then if there's a tumor, brought the patient back and operated. With that one, obviously, you have to liaise with the radiologist, you have to keep the MRI open, and you have to have a radiologist there, then radiologist to interpret the amount of logistics that adds to the actual operation and all the organization. And the radiologists are not the easiest guys to stay late to do a MRI or to do a repeat MRI or to report. Then the intraoperative MRI, I have used it as well. Not much experience, but I have used it, and just setting up, certainly in the ones that I have used, just setting up the patient on the intraoperative MRI is as much of a skill set as doing the brain surgical operation. And when I started in one department, I knew that it's going to be hard for me, so I got the surgeon who has been doing it for the last 5 years and was a master surgeon, and I thought he would just come and just position this is for a posterior fossa tumor, and then he will go, and it took him about 50 minutes to position the patient to get it right. And this is for someone who is a master surgeon who has been using intraoperative for every case for the last 5 years. And once again, then by the time you start the operation, it's already 12 or 1 o'clock in the UK, and then you want to then you start the operation, then you have to get the patient to MRI back. I mean, it really one operation you can do with the intraoperative MRI. Then I have worked in department where they don't have intraoperative MRI. They try to make use of ultrasound. And, as Llewellyn said, if you are quite au fait with using ultrasound scan, you can be pretty good even for biopsies and tumor resections. Particularly, I saw a brainstem glioma or brainstem lesion coming into the superior cerebellar peduncle. And in the previous hospitals that I have worked, we would have used a frame-based biopsy. We once again easily take half a day or more. And the consultant did a beautiful surgery with just the ultrasound and biopsy, before you say hello. And so I think knowing how to use the ultrasound is great, but it's knowing the ultrasound, because I tried to use an ultrasound for a case for a posterior fossa tumor with an intraparenchymal lesion, a small one. And, I was able to localize the tumor, but once I thought I had resected it, then trying to figure out that I have resected it or not, which is artifact, which is blood in the tumor cavity, I really found it difficult. And in terms of getting that learning curve, Llewellyn, what do you say about that learning curve? Because to be honest, and you are running courses, that's fantastic, but certainly, our radiologists, we don't get that much training by the companies. And you can be just blind leading the blind, and then you have got different machines that you have used. So that's the thing. What's the learning curve for using this ultrasound for tumor surgery?
Yeah, thanks, Naren. I mean, those are all such relevant points. So I'm going to start with your last point first. So I think one needs to bear in mind, despite some of the history that I've shown, it started off trying to diagnose brain tumors. But as neurosurgeons, I think we're a reasonably pedantic bunch. We don't like to do things that are counterintuitive. We like doing things the way we're taught, the way we're comfortable doing them. So, MRI scans are always sagittal, coronal, and axial, and interpreting anything outside of that, plane of imaging is very counterintuitive. And I must say, when I started off with this, doing them, there was a guy, actually, the first time I learned, Abir Chakraborty, you may remember him.
Sure, I know him, Southampton.
Yeah, he was doing this at Great Ormond Street, and he had been doing all sorts of really good things. And I watched him do it, and I chatted to him, and I realized, the potential of using this once you get over that that kind of painful learning curve. So it's steep. I think it's steep to start off with, but it's not a long, steep curve. I think once you get over those basics, what type of machine, what type of probe, how do you adjust them, who helps, how do you drape the probe, your whole sort of protocol, and the staff in theatre or the registrars get used to it. I think everybody then finds a team role there. And then that learning curve becomes a lot shorter. So it's steep but short. And once you get used to it, I think you at least most of the people who use it routinely find that it then becomes such a useful kind of reproducible type of imaging modality. Yeah, I hope that answers your question a little bit.
Absolutely, and I agree with you that when it works well. But I have worked with Abir actually, and we tried to put a VP shunt, and we ended up putting it 3 times in that patient, 3 different occasions with ultrasound scan. After that, I stopped using ultrasound scan, and how Abir is good at ultrasound scan. And so, the problem with ultrasound scan is if it works well, but if it doesn't work well, you are then left with a big gap. Am I right in that judgment, or am I what I'm saying that when it works well, fine, but with the MRI, when you have got the actual image, we are the whole picture. But if you can't quite figure out in an intraoperative ultrasound, then you are kind of lost. Am I right in that or not?
I think you are. I think that's a fair statement to make. And I have had cases, even fairly recently, where I have not been able to get useful information from the ultrasound. And that's why I showed that case with that high-grade tumor. It can be quite, difficult to interpret. So I think you're right. I think I'm certainly not saying that in every case that you do, the ultrasound gives you great quality information. But by and large, I think the more you use it, the better that curve starts to move in your favor. So I agree with you. There are cases where you just would not be able to get use from it. But I think that the number of those cases will become less and less the more you become proficient with its use.
Just one more question before I open to the faculty and the participants. When you are doing ultrasound in a spine, patient is prone, you can fill the cavity with saline, then use the ultrasound. Everything is in a very stable system. But when you are doing ultrasound in a patient with in a supratentorial or even posterior fossa operation, where gravity is taking the fluid down and you don't want to push so much on the brain to get a good contact, I find that a bit difficult. Do you have any tips for that?
So that scan I showed from German Ungsgaard, where he shows the positioning of the the position of your patient, and if you can try and get your craniotomy always at least in some sort of 90-degree angle to the floor, so you don't end up losing fluid over the side of the craniotomy on either side. It makes a big difference. Now that's not always possible, because not all tumors follow this prescript of trying to make life as comfortable for you as possible. But there are certain basic principles that you could use in terms of positioning, in terms of the type of fluid that you use, and in terms of how the actual probe is prepared. So if you could get gel into that space beforehand, I think, it helps a lot. So those little things just increase the chances of you getting the best quality imaging. It's certainly not a certainty. I don't know of anything that is, but there are certain things that you could do to improve the chances of optimizing your image quality.
Thanks. Dr. Klaas, do you use intraoperative ultrasound or intraoperative MRI?
Well, we use intraoperative ultrasound for routine, basically with certain indications, but we have no intraoperative MRI available up to now.
Thanks. And how useful do you find the intraoperative ultrasound in pediatric tumors?
Well, it's a good tool to control the extension of the resection also. So we have a good quality machine available for now, and we can control our procedure and can control very nicely what is left from the original tumor. That's really helpful in these patients.
Thanks. I think what Professor Paediatric said, knowing your machine inside out probably gives you the confidence to make the most of the machine. I think, am I right in that, Llewellyn?
No, sure. Absolutely. I want to make one point that I've made a few times before, that intraoperative imaging, ultrasound, monitoring, endoscopy, whatever you use as an adjunct are exactly that. They're just adjuncts. They don't take away the fact that you need to be properly trained in terms of your anatomical knowledge, in terms of how well you've studied the MRI scan beforehand, in terms of how well you've planned. So nothing can take away from those sorts of things. I've got to make that point. You need to bear in mind that you can optimize your ultrasound or whatever it is you do it, but these are merely adjuncts. And if you haven't planned well, and this is an operation that was destined to not go well because of things like that, poor planning, no adjunct is going to change that. And we need to just bear in mind that quality of training and planning doesn't get surpassed by any adjunct that you use. It adds if you planned well, but doesn't make any difference if you haven't.
Thanks. Professor Grottenhuis, it's the same thing with endoscopy. You want to know for a new surgeon, you want to know the endoscope inside out so that you can concentrate on the operation rather than trying to figure out the endoscope in the middle of the operation or having a fight with that. I suppose same with ultrasound scan. Before you even use it, you really want to know it inside out before.
Oh, absolutely. You need training to do that. You need training for any adjunct that you do. I mean, this is not all self-explaining. ultrasound, the intraoperative ultrasound, the big advantage is that it is really real time. So what you see is what really is there at that moment. And we have intraoperative MRI, but if you mentioned that, Naren, that it is quite a burden to get that patient to this other room, which is just one door aside of that, and then bring it back, while it takes another 15, 20 minutes before you really can proceed with the procedure. And I think, well, it's not that important for, let's say, a macroadenoma to see how far the resection was. Not a lot will change. But the ultrasound, really, it is on the moment. But I know from the younger residents, they are confused. They don't know what they see, because it really depends in the direction. If you go, so you have to get the understanding of what you see on an ultrasound. The moment you get it, and fortunately, the equipment is getting better and better. If you compare it to the initial ultrasound in the 90s, this is much easier, and the resolution is so much better. This is a useful tool, but again, you have to have proper training, and then you can understand, and they can use it properly. That's the same with endoscopy, but also the same with intraoperative MRI scan. The same with electrophysiological monitoring. If you have no clue about these potentials, if you have no idea what that is all about, and only somebody else have to tell you what is going on, you better don't use it.
I think that's a very important statement that you make, that you need to know the instrument well ahead before you go into that operation. You shouldn't be like a spinal surgeon asking the rep how to put this and this together on a brain. Okay, it's fine, you can take your time maybe. But
well, I still remember from the very early periods of the early 90s of an endoscope, when people became enthusiastic, that I received a phone call from a colleague, well, actually a very, very good neurosurgeon, said, what should I do when I'm doing endoscopy in a cyst? How do I find where the ventricle is? Well, and I started a kind of theoretical explanation, but then I realized that he actually had borrowed, well, he had get an endoscope in by a representative of the company. He placed that endoscope in the cyst of a patient, and then it turned out he had no clue. So he took the nurse used his mobile phone and said, "What should I do now?" And I mean, this is something we should not be confronted with. You start only when you understand what you are doing. When you, as Llewellyn was saying, you need to know the anatomy. You have to understand what you're doing. But this is a general surgical principle. I mean, this is we have to prepare. We have to plan. We have this kind of rehearsal already in your head while you are walking to the theater. You already know what you will do. That's the essence.
Thanks. Thank you very much. Professor Mazumdar, do you use intraoperative ultrasound in your practice extensively?
Yeah, I absolutely word by word echo what Professor Gurten has said. So we don't have intraoperative MRI because it is prohibitively expensive and we don't have that infrastructure. But intraoperative ultrasound, yes, I myself have not used it extensively, but my colleague uses it. So as exactly Professor Gurten said, that I am still, although it is very impressive, and I really would like to sort of get more into it, but I'm still very comfortable with whatever tools I have and my understanding of anatomy and the tumor and getting to the bottom of it. So yes, I am impressed by the ultrasound, whatever is being used in our department. But same myself, if you ask me, that I'm not still very much comfortable, because maybe I've not got to the extent of what Professor Gurten said, that you have to kind of get the hang of it before you start using it or before you get into it. So it is an impressive tool, and this newer ultrasound which I've seen, and just across it, Tata Memorial, I have actually seen Dr. Ali using it, and yes, it's quite impressive. So I would like to sort of further the experience with Professor Gokula said. And thanks, Levin, for a fantastic lecture. I was impressed with your photographs. So maybe that's the crux of it. So a fool with a tool is still a fool if you don't know how to use it.
And sometimes you can underestimate that it's so easy. Ultrasound scan, it's old, so I can't figure it out. I think sometimes you have to respect that it is a horse that you need to know, and which settings to use, etc. And to be honest, we rarely get any training on that before we use it. Professor Mandera, do you have any thoughts before we go to Professor class? Thanks.
Yeah, we don't have intraoperative MRI, so we cannot use it. But we have used for the last 2 years intraoperative ultrasound, and we find it especially useful for positioning of the drain in hydrocephalus, but also in some tumors. We also use ultrasound to better visualization of the edge of the tumor, and especially when we remove the tumor, and we are not sure that we removed it totally, we sometimes help with ultrasound to look for the remnant of the tumor. So I find ultrasound is very useful.
Thanks, thank you. I think someone, just as a summary comment, Llewellyn, if I may say, thank you very much for that. A very important talk. I think sometimes we can all get into this idea that we have to have the intraoperative MRI. That's the standard or gold standard. And Dr. George Jallo just today gave a lecture where he mentioned that they don't have intraoperative MRI, and so it doesn't have to necessary that you need an intraoperative MRI, but knowing your tools and making the most of your tools, and respecting the fact that you need to learn about the tools, not to underestimate the engineering mind that has gone into creating that stuff. There's a lot of thought that they have put. That's why they have put so many knobs on that thing. And I think you can get a lot out of ultrasound scan. And I'm glad that Llewellyn is running courses, and I hope he will run courses for £10 so we can all come to the beautiful Pretoria and use the money to travel to you. But Llewellyn, the only criticism I can have, maybe this is not the right place to say, is that these ultrasound courses are so expensive to come. The course fee, they are quite a lot of money. And when particularly these companies are sponsoring it, and just to give I started these courses myself because I wanted to have a competition for courses so that they have to fear there are people doing courses for low cost. I looked at when I was trying to do this course on tumors, and first day was on molecular biology. I saw a course that was run in Southampton 2 years ago before COVID on molecular biology for surgeons. And it was a didactic course, 1 day course, 6 people or 7 people from Britain giving talk. Guess how much they were asking for that 1 day didactic course in a room? How much they were asking for that? They were asking £500 for that course. You know what I mean? Sometimes courses become a money-making machine. And I think these ultrasound courses where companies will fight over each other to give sponsorship and give the machine. I think it's worth running courses which are not so expensive. But the problem is that there are so many different machines. And unless you know the machine, then it becomes difficult to make the most of it. Any comments, Llewellyn?
Those are very relevant points. I think broadly, when one runs these courses, how much is charged, I think is always a contentious issue. And I think you're very right in some ways in saying that, what's the incentive in running these courses? So for the ultrasound courses particularly, so I'll give you a bit of personal opinion there. We've run now a few. I would have thought with this group that have have sort of come together to run this intraoperative ultrasound course. 1, 2, 3, 4, 5, 6 of them, I think, done online because of obviously because of the kind of situation that we're in. And these were all free courses. So there's a group in Italy who, in Carlo Besta, that have developed a simulation tool. So the difficulty with ultrasound is one of those hands-on things. You need to be like endoscopy. It's very difficult to run a course virtually. But the simulation tool, and there's a website, it's called Neurostim. I think if you go to Neurostim, you can register. And I say this under correction. It's not my website, but I think it's free. And I think you can register for free and your cell phone in a very smart way. So it's artificial intelligence based and learning algorithm based to learn the basics. So there are these things now. I think depending on where in the world these courses are run, the cost for these courses, differ quite a bit. And in India, there have been a few that have been run at a very reasonable cost. We ran one only, I think, here. I think the cost was reasonable. You can give me some feedback. But depending on where in the world you are, it's going to be different, So I think it's difficult for me to answer that. I support the context of what you're saying, but different people run them, at different costs.
Well, the courses in India are quite reasonable. If you see at Tata, Ali is running quite a reasonable course, I feel. You have been a faculty there.
No, absolutely. And look, the thing is, I know creating the models, getting people to come, some of the faculty, need to get paid to come, they're coming from far. Those are costs one has to cover. Those are things I realize. But generally, I think the context of your statement is reasonable, and should more effort be made to make these and other causes a lot more cost effective, for sure.
Thanks. Thank you very much. Thanks a lot, Professor Paediatric. That's fantastic discussion on ultrasound. Once again, I do urge people to get over with the ultrasound. So this brings us to the last session of this today, as well as the last session of this 4-day course. It's on hydrocephalus in patients with brain tumors. So if I may ask Dr. Dieter Klaas, Professor Dieter Klaas is at the University of Magdeburg in Germany. I have known him now, I think about 10-15 years. He's one of my closest friends, but he's a very thoughtful and very humanistic neurosurgeon. And this problem of managing, sometimes as with anything, managing a patient is not just about the tumor, it's about every small aspect. And sometimes you can have a very good tumor excision and then patient gets screwed by CSF leak, hydrocephalus, pseudomeningocele, etc. So it's always important to be very mindful of the whole patient care, not just taking the tumor, considering that operation for tumor is just taking the tumor out. So Dr. Dieter Klaas, look forward to your introduction to this topic. Thank you.
Thank you. Everything okay?
We are not seeing your presentation yet.
Sorry.
We are not seeing your presentation yet, Dr. Klaas. Are you sharing it? Not yet.
No? Just...
Sure.
Is it working now?
I can't see it. Does anyone else see it? No.
So, just...
No, not yet. Not.
Sorry, Naren, I get some support from my colleague. Just a second, please.
Thank you.
We are trying to fix the problem.
No problem. Yep. This is what happens when I try to use the ultrasound.
Okay, is it working now?
Yeah. Yes. Thank you. Yeah.
Yes, and go in presentation mode. Perfect.
Thank you.
Yes.
Okay. So first of all, Naren, I want to thank you very much for the invitation to join this excellent round. And I also want to thank Professor Sanatioglu, who is the head of our department, who followed Professor Fisching, and he always contributed to this work, and we appreciate very much to be here in this excellent meeting. The topic of our talk is the management of tumor-related problems causing hydrocephalus. A short overview. I want to say some comments about possible causes of hydrocephalus, treatment necessities, treatment options, and problems to solve. As I know there are always some younger neurosurgeons in this round, I also want to come back to some basic comments about this important issue in dealing with children with brain tumors. So what are the possible causes for hydrocephalus in children and adults with a brain tumor? We found obstructive hydrocephalus due to a space-occupying lesion in the posterior fossa, especially affecting the fourth ventricles. We find tumors causing obstructions in the CSF pathways in multiple different sites, like the foramen Monro or the aqueduct himself. We find hydrocephalus due to the secretory properties of a tumor like a plexus papilloma. Sometimes we find with persisting communicating hydrocephalus after successful removal of a lesion causing obstruction of the CSF circulation, and speak about problem of CSF absorption, which can end up again with intracranial hypertension. Sometimes we see problems in CSF circulation resulting from CSF leakage. Post-hemorrhagic hydrocephalus after intracranial bleeding is a finding we see quite often, but we have to keep in mind that often the cause for a problem with a CSF circulation remains finally unclear. As Dr. Buffet yesterday mentioned, chances for a child with a brain tumor to survive are completely different according to the country of the birth of the child. Socioeconomic conditions are important. What is available and who is available are fundamental questions. But we have to accept that there are definitely things we cannot change at the moment, but still we can work on future perspectives to close gaps. And your work, Naren, is really a very powerful tool in this context. When we see a child with hydrocephalus due to a brain tumor, we can basically divide these children in three groups. Children may present with a lesion like a granuloma affecting the pineal region, and these are well-known tumors which respond very well to radiation. Lesions in the suprasellar region and producing high prolactin levels may be diagnosed as a prolactinoma, and they respond very well to bromocriptine treatment. Of course, these children can basically be treated without shunting. The diagnosis can be made on radiological findings and on laboratory testings. The question we sometimes have to deal with is the question, how long can we wait until a tumor responds to bromocriptine, responds to radiation therapy, especially when hydrocephalus is seen, and the question is to be discussed, what is this meaning for the child in this concrete situation? The next group includes children with hydrocephalus and a brain tumor, like in this girl 2 years of age, who presented with a lesion in the ventricle on the right side which could be removed well, turned out to be a choroid plexus papilloma, and this tumor never recurred. This boy, 10 years of age, presented with a hydrocephalus due to a ganglioglioma. The tumor could be removed and the child was cured finally and went away without shunting. And we all know about the typical lesions involving the aqueduct on the basis of a lesion in the mesencephalon causing occlusive hydrocephalus, who can be treated well with endoscopic ventriculostomy. But on the other side, we have to accept that these are good conditions for a child with a newly diagnosed brain tumor, but due to longer survival chances for these children, there's still a risk of recurrence of the tumor, ventriculostomy occlusion, and a newly developing hydrocephalus. So even in these children, there's still a risk that we have to fight with hydrocephalus problems later on. The typical situation in the emergency room may be reflected with two patients we saw only recently in our department. A young boy who was 10 years of age presenting with massive intracranial hypertension due to a lesion in the fourth ventricle causing occlusive hydrocephalus. Our strategy with this boy was to put an external ventricular drainage, and we went for removal of the tumor next day. The boy, 1 year old, presented with similar symptoms. He was vomiting and suffering from true signs of intracranial hypertension. In this child, we went straight forward to remove the tumor. The reason why we did this was the situation that this tumor extends far above, and we were concerned about an upward herniation of the brainstem in case we only put a ventricular drainage to reduce the hydrocephalus. What are the thoughts about these children with lesions in the posterior fossa? Is it an option to place an external ventricular drainage first and wait until intracranial pressure is slowly reduced? Is tumor removal as a first step with an EVD an option, or should the tumor removal be the first step without EVD placement, hoping CSF pathways are open again? So these are questions which are to be discussed, but there are only probably individual solutions. There's no possibility to formulate a general guideline for these children. What are the basic questions when we have to treat a child with hydrocephalus? The question is, does the patient really need a treatment? And answering this question, it's always worth to review the whole course of the disease. Are there progressive signs of intracranial hypertension to be noted, or do we see something like a hydrocephalus evacuate due to atrophy of the brain and surrounding structures? Are endoscopic options to be discussed to avoid shunting? Are there other options to treat, like temporarily supply the child with a lumbar drainage or to proceed with repeated lumbar punctures? Supposing that the patient really needs a treatment and endoscopic procedures are not an option, we have to answer further questions. Do we see an internal hydrocephalus? Is the ventricular system primarily involved, or do we see a progressive collection of fluid in the subdural space looking like an external hydrocephalus, or do we see a combination of both? We saw some years ago a boy, 8 years of age, presenting with a massive hydrocephalus due to an astrocytoma in the suprasellar region. The boy was operated by a transcallosal approach, and the tumor could be removed practically completely, but for some time we had to fight with the subdural collections, and we were facing the question, should we drain this? Should we put a shunt system to help this child, or what would be the optimum treatment for this boy? So the question always has to be answered, which compartment should really be drained? So coming back to questions of treatment, the etiology of hydrocephalus should always be discussed again. May conditions of disease and treatment possibly change, like in children with posthemorrhagic hydrocephalus? We have to keep in mind the age and the weight of the child, think of possible problems of wound healing, and we have to take into consideration an expected length growth of the child. And of course, the neurological condition of the child is always important. The question, may siphon effects be relevant? As we all know, shunt systems include three basic components: an inflow catheter, mostly a valve system, and an outflow catheter. We already mentioned endoscopic procedures, so the next question is, what kind of hardware should be used to help a child with hydrocephalus? Should we go for a reservoir? Should we go for an external drainage? Or should we use one of these multiple valve systems available in the market? I want to make some comments on the inflow catheter, which is really a problem in cases of children with hydrocephalus, where the question of intraventricular chemotherapy has to be discussed. It's very important to look for a precise placement of the catheter, and only the tip of the catheter may really end up in the ventricular system to avoid any infection of the white matter due to drugs which may not be collecting only in the ventricular system, but also enter the right substance. So when we place these catheter, we always use contrast medium to confirm correct catheter placement. When thinking of placing a reservoir, which is an option in treatment of preterm born babies with a weight of less than 1 kilogram, and for removal of CSF, we can also use this for intraventricular delivery of antibiotics, chemotherapy, and contrast medium. We all know about this, but it's always important to look that the precise needle is used to avoid damage of the reservoir. This is a special designed tip of the device just to avoid damage to the material, with the effect that CSF cannot leak through the skin finally and put the child on the risk of infection. So the key features of a valve system which may be used in treating a child with hydrocephalus related to a brain tumor: the protein tolerance of the valve, the possibility to puncture the valve, or at least a component of the shunt, and of course the possibility to change pressure settings of the valve in the situation when the conditions change, when hydrocephalus is already treated and there are signs, let's say, for hyperdrainage, and the option would be to adjust the pressure settings. Often children are introduced by our oncologists with a question of the intraventricular chemotherapy, and this is sometimes causing also some technical problems. The ideal solution, of course, is a VP shunt and a separate reservoir in addition, just to avoid infection and just to make sure that the handling is easily to be managed. But also there are children already supplied with a VP shunt, and then the reservoir connected to the shunt can be used for application of chemotherapy. But still, it's very important to make always sure that the catheter is in proper position, really. What are some practical aspects in the management of these children which should be mentioned, especially in this talk. We are used to closing or adjusting the shunt valve to high opening pressures under clinical control. Then the reservoir is punctured and the drug is administered, which is left at least for 20 minutes in the ventricular system. Then we open the shunt or readjust the shunt valve pressure. And it's very important to keep a close eye on sterile surroundings. It's mandatory that only those special needles are used, but there are still many open questions referring to pharmacokinetic and pharmacodynamic aspects of this intraventricular chemotherapy. So there's probably place for discussion about options in handling these problems with local intraventricular chemotherapy. We should just give a short comment on the distal catheter placement. We are all used to ventricular peritoneal shunt placement, ventricular atrial shunt placement, but only recently we saw 2 patients where this was absolutely impossible, and we finally supplied them with a ventricular pleural placement. This so far went well. Of course, this is an exceptional solution, but there are definitely some desperate situations where you have to find an individual solution. So the question, VP shunt and VA shunt are not possible. What is your option? So thank you very much for your attention. Sorry for the delay in the beginning, and I would appreciate your comments. Thank you very much.
Thank you very much, Dr. Dieter Klaas, for that excellent overview of the vast number of different scenarios hydrocephalus comes into play in patients with brain tumors. I think if we choose a couple of two areas to discuss, because I think there are so many points that you highlighted. In terms of the posterior fossa tumor, the patient comes with hydrocephalus, and in your institution, do you put a EVD? Do you do a endoscopic third ventriculostomy? Do you start the patient and observe whether there's any deterioration and then operate, and during the operation put a EVD, or you don't put a EVD at all and then hope that after the tumor excision the hydrocephalus settles down? Which one do you go for in your institution?
Well, this is a good question, which summarizes the main points I already mentioned now. I mean, we never go for ETV in these children because often these are critical situations and we want to be sure that intracranial pressure is controlled well. So for routine, normally we supply these children with an EVD, and then often the diagnostic procedures have to be completed still. Some children were introduced just with a CT scan showing massive hydrocephalus. And so the first step in these children is always an EVD, then completing the MRI scannings. And we have to keep in mind that also the whole spine has to be shown in MRI imaging. So to answer your question, the normal way is put an EVD, look how the child is doing, and then we plan the removal of the tumor in the posterior fossa. There was this boy, 1 year old, and this was a desperate situation. The child was in a bad situation, and I was really concerned with my colleagues about the question of upward herniation of the brainstem in case when we reduced the hydrocephalus. Actually, it would be an interesting discussion if in the audience somebody has seen this quite often in clinical routine. We were afraid, so this child was operated without the EVD placement. We went directly to operate for the tumor.
Thank you, Dr. Peter Klaas. This is a controversy session, so we'll try to generate a controversy. Mr. Richard Edwards, you are here. Thank you. Thank you very much for being here. And I know that in Bristol, we preferred, if we were going to do diversion, if I'm right in doing ETV, what do you say to Dr. Dieter Klaas that with the ETV, you can't be sure that it's actually working, and also that the small danger of upward herniation, and do you get a decompression, uncontrolled decompression that can cause bleeding? I mean, I'm purposefully trying to ask you these questions. Thanks. Richard, are you there? I think Richard's mic is not probably working. Mr. Edwards, is your mic not working? While we are waiting for Mr. Edwards to come online with the sound, Professor Groton-Hughes, do you have any thoughts, ETV versus EVD versus nothing for a posterior fossa hydrocephalus with a GCS of 15 or kid with a headache?
Hello?
Hello?
Sorry,
Hello?
I dropped out for a minute.
Oh, that's okay. So, Mr. Edwards, I was saying that Dr. Dieter Klaas, when there's a posterior fossa tumor, he prefers EVD over ETV. And I was asking you, in terms of ETV, the concerns were that, you are not sure that it's actually treating the hydrocephalus, if there's also an element of communicating hydrocephalus, and whether ETV also has a chance of upward herniation or decompression causing tumor hemorrhage. This is a controversy session, so I'm trying to generate some controversy. Thanks.
Yeah, I mean, I think our experience has been that ETV in general works well for these patients. I mean, they're some of them can be tided over with dexamethasone if you've, depending on theatre scheduling and so on. But the ETV does give us a bit more flexibility in terms of scheduling cases, particularly if they need a lot of setup and organisation and monitoring and so on. I think, different healthcare economies will have different access to these sorts of things, but sometimes we'll have to prepare a few days in advance. We've not seen a decompression with upward herniation. I think it would be potentially a risk, but I think it would be a small risk. I think if there was a tumour that had that much posterior fossa mass effect, there'd probably be other signs of brainstem compression and so on that would probably precipitate emergency surgery anyway. We have had, I think, one case certainly that I recall where we've had intratumoral hemorrhage in a delayed fashion following ETV, whether that's related to a decompression and you disturbing the hemodynamics within the tumour, I don't know. I think it's certainly a possibility, but equally, if they've got acute hydrocephalus, I think an EVD could easily do the same thing. I don't think we know the thresholds for these things, and there'll be an acute point of decompression when you put the EVD anyway. So I'm not sure that it would there'd be that much difference in risk. I think both are reasonable options, and an ETV does seem to temporize things effectively. But I think there are some patients where they present with lower grade hydrocephalus where you can temporize them with steroids and then operate on them without external drainage, and those are a little bit more straightforward.
Thanks. Thank you, Mr. Edwards. Professor Groton-Hughes, the ETVs that I have done I've not done many ETVs with the tumors, but when I have done, the floor is not like in a chronic hydrocephalus, is thin, and diaphanous that is easy to make a hole. Is usually quite thick, and it's more challenging than a normal ETV that I will do for a chronic hydrocephalus. What's your preference in terms of posterior fossa tumor EVD or ETV or none until perioperative EVD or none?
There is no standard answer to this, Naren. But I agree with you. The ETV in an acute hydrocephalus is different. In the chronic hydrocephalus, you see this typical thinning of the anterior part of the floor in front of the mammillary bodies. It's quite easy. In an acute hydrocephalus, especially in posterior fossa tumors, there is very little space between the mammillary bodies, the brainstem that is pushed towards the clivus. And so there is little space actually to do an ETV. There is a little trick that I use when I do an ETV. That is, I make the opening on the clivus, so on the dorsum sellae. That's a safe spot. That's bone. There will be no bleeding. You can even take a grasping forceps. You tear off a little bit of that floor, and then you take a little hook and you push that backwards. And then you can enter with a balloon catheter or anything else into the interpeduncular cistern. So that's just a technical trick. If that is really necessary, well, I prefer, if it is possible, to remove the tumor, which is actually the cause of the hydrocephalus. Not all of them will stay shunt-free or ETV-free afterwards. They still can have hydrocephalus. Typically, and I think all of us know that, these patients are seen by general practitioners, then by the pediatricians, and they will send it to the neurosurgeon on Friday afternoon, 6 p.m. Because then they think, oh my goodness, this sick child vomiting and not doing well, we don't want to have it here, we better send it off now. Well, in many institutions, it's not so easy. So temporizing it to a, let's say, more possible time to do the surgery can be done, as Dr. Edwards was saying, by dexamethasone. It depends on how the child is. If you have a child in extremis, one of my last children that I operated during my career actually was on Christmas Eve, coming in already for months, having vomiting and things. Well, but she was more or less coning in that situation. And it was a pilocytic astrocytoma. Well, we went in there, and within less than 2 hours, the whole surgery was done. At one point, you have to do it. And I prefer to do it. ETV is preferable to external ventricular drainage, just out of a practical issue. The case that Dr. Klaas was showing, this 1-year-old, he was fully right. If you saw how big already this tumor was bulging into the posterior hiatus, well, if you release some CSF, that will completely block the hiatus, and you have over the difficulties. So that was the absolutely best decision to go straight forward. I would indeed not dare to do any CSF diversion. So I really agree with that. But now you have an external ventricular drainage frontally. At least in my institution, the smaller children, they are operated on the cerebellum in a prone position. That's a hazard. I can just tell you, positioning the child, you have to close the external ventricular drainage. And I have actually also already seen external ventricular drainages falling out during positioning. Oh, we don't know, what is this? What is this? And then the whole external ventricular drain was already off. So I simply don't like it from that practical standpoint. If you really want to temporize, and the child is still fully awake, and then I do with dexamethasone. Next morning, I can have my proper team doing the procedure, and that's fine. The child in extremis, I go immediately for the tumor. And in between, if the hydrocephalus is there with a smaller tumor, I do an ETV. So external ventricular drainages are rather rare. Then, of course, the way I was trained in the early 80s was doing the surgery, but making an additional burr hole here occipitally to be able to puncture the ventricle if necessary. I rarely do that. I'm honest, I drape a little bit higher up, then it is fine. You more or less can do that intraoperatively. Conclusion, tumor removal is my preference number one. If it is not feasible, then I temporize with dexamethasone, if that is possible in the child in good condition. If it is not, it is an ETV. So that's the, let's say, my policy in those cases.
Thanks. Thank you very much, Professor Groton. You made the point that the space might be very narrow to do a ETV, and you do it over the clivus. And the only case that I had done where you obviously the floor was not translucent, so you didn't really see the clivus. You from the anatomy you thought that was the clivus, and then we made the hole and it worked fine. And is that the experience with the other cases that you do the ETV, that you don't actually see the clivus, as in a chronic hydrocephalus? You are looking at the anatomy and the prominence, you assume that to be the clivus, and then you make a hole in that area?
Well, I don't know. You mean in chronic hydrocephalus? Yeah, well, you actually can see.
No, in chronic hydrocephalus you can see, but in acute hydrocephalus, that's in like these tumors, do you actually get to see the clivus through the floor of the?
No. But no, you were right. You can't see it, not always, but this is what I call palpation. You have a blunt instrument, and and sometimes even just with a little bit of rinsing, but I'm reluctant to use that when there is no opening yet, because it can't go away, and a little amount of fluid can already raise to a higher pressure. But you can just feel in front of the medullary bodies, and you feel where that clivus is, where the bone is. It is not always translucent enough to see it. That's true, but somehow it's difficult. I should be able to show some examples that you get anatomical clues to it, because you see always in little children, in infants, the mammillary bodies are not always reliable. They are not so clearly visible. But the infundibular recess is always visible. So you can go backwards from the infundibular recess and then find the clivus.
That's great, thanks. Mr. Edwards, if I can come back to you, when you do a ETV, has there ever been a situation that the ETV has gone well, but the hydrocephalus has not been treated in the setting of a tumor, that there was an element of communicating hydrocephalus? Have you come across that ever, or is it usually just always a obstructive hydrocephalus, usually ETV works?
No, in our experience, an ETV preoperatively does work. I think I very, very similar experience to Andre. When you do encounter the floor where it's slightly opaque, you can sort of almost feel your way through it. We do a blunt. We use a flex blendoscope normally and do a puncture with the flexible monopolar electrode. Again, aiming relatively anteriorly, and you can feel the clivus as you pop through. And I'll often just gently, without going too deep through the floor, just move the scope slightly side to side, and then withdraw the stylet just to open up a small opening, and then you can look through and often see the basilar behind you and the clivus in front of you. Then you know you're safe, because once you're in front of the basilar, you're safe. And then you can put the balloon in and make the ETV. There are some other tricks you can use. because we use a flexible scope and a peel away port introducer, we can use the Axiom stylet, just passing it just slightly in front of the flexible scope, and you can navigate it through the Fraber Monroe and just use the tip of that stylet just to identify exactly where your basilar is in relation to the clivus and so on. That can give you a little bit more reassurance. I think you need to use all of these things together though, because all of them can be a millimetre or two out, and you've got to be cautious. And the most important thing is you don't push the balloon behind the basilar and then inflate it, because you'll just rip the basilar off the brainstem and tear all the perforators off, and it will end in catastrophe. So, you know, you've got to be quite sure that the basilar artery is sat behind you, and once you can see that, and you're confident you can see that, then you know, you're going to be relatively safe. And if in doubt, just very cautiously widen the stoma, keep checking, looking, and but you want to see that clivus in front of you. The other thing that I would add is that, as you're aware now, we routinely put a ventricular access device in at the end. And I know this is another area of controversy, but again, in these cases, it's useful because post-operatively they can develop, for example, a communicating hydrocephalus, or have a bit of residual ventricular megaly. You're not sure whether it's significant or not. You could do an infusion study or pressure monitoring through the access device. So, you know, I think there is some controversy about putting in a VAD at the end of an ETV, but particularly in these sorts of cases where you often need periprocedural ventricular access, or there may be a risk of a communicating hydrocephalus developing post-operatively, then you know, having this there to facilitate further diagnostic testing, pressure monitoring, infusion studies, and so on, really makes you know, I think the perioperative course a little bit more straightforward. And you know, there's still a prevailing view in neurosurgery that an ETV's advantage is it's a hardware-free procedure. You know, I don't hold with that. You know, we put lots of hardware in and leave it; it's not a big deal. But you know, the advantage of an ETV is that you haven't got you know, a shunt that drains CSF and can overdrain or underdrain and cause all of those problems. It sort of internally neutralizes things. And, you know, one of the problems is that sometimes you can have a sort of compensated hydrocephalus after an ETV, and you may want to assess it at a later date. And, you know, if the child's school performance isn't as expected or something like that, you may want to see whether they've got a sort of partially compensated hydrocephalus, and an infusion study via that access device can be quite useful in those settings. So, and I think the ETV in the setting of a post-Fossa tumour, you know, some, you know, whilst, you know, you could argue that, well, you've taken the tumour, you've cured the hydrocephalus, actually, you know, sometimes you do get a fourth ventricular outflow obstruction after, not infrequently, after a post-Fossa tumour resection. And actually, ETV will reduce your instance of shunting in the post-operative period because of that. And so, you know, they're not all communicating hydrocephalus. In fact, I think a minority probably are, because unless you've really not protected against a, you know, extensive spread of blood intraprocedurally, you know, I think communicating hydrocephalus is probably less common, and it's often a fourth ventricular outflow and scarring at the obex that causes the problem. So I don't know if Andre wants to comment on that, but
Professor Grotenius, do you have any comment? With the ETV, when you put an EVD, you know that the EVD is draining, and then you take the EVD out. If the ventricles are still large, or then, you know, you go ahead and put the shunt. But when you have a ETV, there's always that question: you can sometimes spend a long time deciding whether you want to put a shunt or not, and have pseudo meningocele, etc. What's your thoughts on that? Thanks.
No, I think you're right. That's if this is the situation, you did a pre-op ETV, and I agree with Dr. Atwood that the pre-op ETV is very effective. Actually, if you just have operated the tumor, and then after a week there is still ventricular enlargement, do an ETV, that's not always successful. But now you have done an ETV, you have removed the tumor. And then still, well, the child is recovering from that surgery. And then you do a post-op MRI scan. And yes, the ventricles are still enlarged. It will really depend on the situation of the child, which is not always easy to assess, because you could always argue, okay, it's going slowly. He's still a little bit unstable in his gait. So you could always say, maybe if we do something about that enlarged ventricle, he could improve more. It's not easy. And that's why I agree with Dr. Edwards that this is a situation for ETV, if you do it in the case of posterior fossa, to maybe leave a ventricular access reservoir behind. I don't do it in regular ETVs without tumors, but in these cases, yes, it can be, because you can study, you can see what it is. You can do infusion study indeed. And actually also in some cases, it can help if it is an ATRT that you have operated or a PNAT or any, you have already the access to the ventricles for chemo. So there are some arguments to do that. I have not done that on a regular basis, but more lately I actually did. So not in the initial phase, but of ETV, we always trusted our judgment and say, that is working, that's fine. But it's not always that easy to make a judgment. But I just want to say that only the size of the ventricles should not be the single criterion. It's really a clinical decision. It's about knowing if there is pressure, yes or no. At least in children, I rarely see this type that you see in adults, what we call the normal pressure hydrocephalus state after subarachnoid hemorrhage, after a tumor surgery. We see that more in the adults, where they still have this. I even not seen in children what we call the low or negative pressure hydrocephalus situation. So in children, this is a more straightforward. Nevertheless, make it a clinical decision where the size of the ventricle is just one part of the equation. It's how the child is doing. Look to all the little secondary signs, as I already described. It's not only the size, it is the secondary effects. Are the cisterns open? You see a nice gyri and sulci. So then it's better acceptable. So we should not make this only on an image, such a decision.
Thanks. Thank you very much, Professor Glotonius and Mr. Edwards, for this nuanced description of the role of ETV and how to proceed with that. There's a slightly different angle on this thing. Professor Mazumdar, let's say that you get a patient with GCS 15 with a not severe headache, but some headache, GCS 15, large ventricle, there's hydrocephalus, you can see the temporal horn, but he's talking to you, and you can't do the operation that day, you can't do the operation next day. Would you be happy to leave the patient without EVD or anything until the day that until he deteriorates? Would you be happy to go to sleep on it? Because I do, and I want to know whether you have a much longer experience, and I just want to know.
Naren, actually, thank you for asking me the question. And let me tell you, this will vary from center to center. And what our experience has been that in my initial training days, as well as till lately, about 10 years ago, we used to see a lot of posterior fossa tumors. We almost see about close to 50 to 80 posterior fossa tumors in a year. So you can imagine that with the existing infrastructure and the patients coming late in the evening, as Professor Glotonius said, that when the clinics are closing that time or on a Saturday evening. So our strategy always has been that if the patient is coming, then we do not wait for too long. We operate the patient same evening, and or at the most on the next day routine OR list. If the patient, most of the time we do not do any kind of CSF diversion for the known complications of shunt migration, upward herniation, intratumoral hemorrhage. We have lost so many patients, and they usually succumb usually in the wee hours, early morning hours or in late, between that 3 o'clock to 5 o'clock period. So we do operate these patients, go after the tumor, and obviously ETVs, we don't do ETVs, we don't do shunts as well. So most of the time we have been able to get away with it. And if you ask me in the post-operative period, even though our threshold for shunt or CSF diversion has been very less, so if there is only persistent symptomatic progressive hydrocephalus, so hydrocephalus, I don't mean large ventricles. So if it is clinical symptomatic persistent, then only we do use a moderate pressure locally devised VP shunt, that is the Chabra shunt, and our experience has been very good with that. We do very less shunting. We almost have done away with shunts unless we have symptomatic clinical reasons to do it. Now the question whether OR is not available on the same day or the next day, I mean, it doesn't happen that well. But if the patient is GCS 15/15, I would rather, if the patient is relatively well, I would rather rely on the buoyancy of the ventricles, keeping the tumor away from the critical brainstem structures, like maybe the midline, the thalamus, as well as the brainstem, rather than try to meddle with the hydrocephalus and have a problem. So we have done so many a times. If the OR is not available in the next 24 hours, patient is clinically well, we would closely monitor the patient, keep the EVD instrumentation by the side of the patient in the ICU. So with this protocol, we have not burnt our fingers of losing any patients or excessive morbidity and so on and so forth. So absolutely, we have not done any ETV. If the patient is very sick or if there is an impending kind of a situation, then only we may resort to a VP shunt. That too, high pressure shunts are not available so easily. So we might end up putting a medium pressure shunt in that case. So my answer to your question will be go directly for the tumor and only do the shunt in the post-operative period if it is necessary.
Thanks. Thank you very much, Professor Masunda. That's very helpful. Dr. Data Class, you are from Germany, and I have worked in 3 different departments where things are done 3 completely differently. I worked in one department where every hydrocephalus has a ETV. I worked in another department where patients don't have a EVD or EVD until they either perioperatively or don't have it at all until the tumor is excised and if it needed. And I worked in other departments where there's EVD or ETV if the patient is symptomatic. How is it in Germany or in your department? Do you guys proactive in you guys go any sort of hydrocephalus and then you put an EVD?
Well, it depends on the clinical condition now, and of course, and these are always very individual decisions, and there are many things to keep in mind. But I mean, coming back to the original discussion, of course, if the option is to go directly to remove the tumor, then would be this probably our first step too. But as I said before, often the child is in a bad condition. Often the MRI is not complete, and there are many open questions to answer. And so this is a situation where probably we would use an EVD as a first choice. But I think there's no general rule which can be given, and no general recommendation which can be formulated. I mean, the main target, of course, is a tumor, no doubt about this. But often the circumstances are different, and we have to take this into account, of course.
Thanks. Thank you. Last point, if I may, Professor Masunda, did you want to make a point?
Yeah. So actually, as the panel would suggest, it is very highly individual decision depending upon the patient and the circumstances, I would feel. So as I told you, for example, in our center where it is a large population with so many patients coming in, and being a major tertiary referral center, we have to accommodate this patient. We can't keep these patients for too long in the ICU or indoor service. So we have to quickly do things, and we have evolved with our experience. So many a times, if we do an EVD or we kept the patient waiting for surgery, most of these patients have not made it to the OR. So we have burnt our fingers. So I would feel that, okay, EVD at the most, tap the ventricle or do an EVD at the most if you have an impending situation, but otherwise just go in for the tumor. And we have kept our anesthesiologists or the infrastructure even during the late evenings. We have monitored the situation where we have enough blood products available, or the anesthetists are there to round the clock to get this situation under control. So the situation would be appropriate if you operate it in the routine OR. That's when you have the senior most anesthetists and you have the infrastructure ready for you. But the patients are of different class. So we have not done EVD unless it's a very sick or it's a very crashing kind of a situation. And most of the time, and we operate the patients in sitting position. So as Professor Grotenius mentioned, that if you are operating in a prone position with an EVD, that's a hell of a problem. But if, in a sitting position, even for a 1.5 to 2 year or 3 year old children, also we have used sitting position with a special kind of a chair, a small chair which we put on, which we install on the operating table. And we are able to operate those patients also in sitting position. So as soon as you open up the posterior fossa and decompress the tumor, the CSF egress from the aqueduct is so fast. So what I do is, as soon as I decompress the tumor, I usually plug the aqueduct with a gel foam and put a patty over it, so to prevent air from going in the ventricles. Because if there is too much rapid decompression of the ventricles, then air might go in and that could give a problem. So obviously we don't use nitrous oxide because it can cause expansion of the air. So that small tricks we use so that and work around so that we avoid the complications of rapid decompression of the ventricles. I have this reported also. A good piece of gel foam you keep over the aqueduct, it swells and it doesn't allow CSF to flow rapidly. And once the tumor is out and everything is fine, then you just take out the gel foam and allow the normal CSF flow to occur. So these small tricks we use to avoid, because shunts are a problem, and then the patients come with shunt blocks, revision, and then so on and so forth. So try to avoid shunts, get the CSF dynamics to your advantage, and remove the tumor as early as possible in the best possible circumstances.
Thank you very much for those tips, Professor Mazumdar. Llewellyn Paediatric, just another scenario that you have a patient posterior fossa tumor operated. Now the patient has developed a large pseudomeningocele, and you have done lumbar punctures, and it's still there. When you put you have now decided to put a VP shunt, and if you put a VP shunt in these patients with large pseudomeningocele, do you have any preference what kind of valve you choose, differential pressure or what pressure, or whether it's flow control or programmable?
Naren, that's a tough one. No, I don't. I don't. I mean, I think the thought process so far is, I think they need to be treated and probably need to get a VP shunt, but I don't have a preference for. We have recently, and we've collected this in a sort of a part of a registrar master's thesis, looked at the gravitational valve shunt in a broader context, not just specifically this. So, I mean, that is an option I think for me is gaining a little more favor, but no, I don't have a specific preference.
Thanks. I used to use not all, I had a penchant for using flow control valve, thinking that the flow pressure might not be high, so I want to keep the flow going. But last week I was reading about flow control valves, and they said that if the pressure is low, it doesn't really work that well. Professor Grottenhuis, did you have any particular choice for valve when you had a large pseudomeningeal seal? Thanks.
No.
No.
I mean, pseudomeningeal seal, that means there is, it only really develops, I mean, either there was no proper closure or there is still high pressure. So it depends on how you want to treat that. I think any valve that you have to choose should also prevent over drainage. And with all the current systems we have, they are all differential pressure valves, from the very sophisticated valves that we have for thousands of dollars up to the Chabra shunt. They are essentially differential pressure valves. And for me, it's always a struggle to think about a valve only, so putting a valve in for a pseudomeningeal seal. I prefer having a temporary, so this is a post-operative situation, then a temporary CSF diversion, and then testing that, see how it is developing, measuring it, and do a reoperation to see if where the leakage is. So yes, I have to commit that there are some cases where simply any pseudomeningeal seal is not treatable surgically otherwise than drainage. Even in the spine, I had cases with spinal pseudomeningeal seals that end up with a VP shunt to finish that part. So I know that it's difficult, but initially, if you think about the problem of pseudomeningeal seal, it's a CSF disturbance, because otherwise it would not develop if you have done a proper closure, of course. So you have to check that, and I want to attack that from both sides. So temporizing the high pressure of the CSF and looking again to the area where the leakage is that could develop into a pseudomeningeal seal. These are the two parts.
Sure.
And if it is not happening, well, there is no standard valve. I certainly would not go for any kind of very low pressure valve. Usually, if that is because of blood or a kind of low grade infection that happened, well, for the last many years, I don't even recount how long that is, we use the gravitational shunts. And I would choose a higher setting of that.
Thanks. Just to clarify, Professor Grottenhuis, I appreciate that there's never one method for all the patients. But if you had a pseudomeningeal seal and if you have done lumbar punctures and if it hasn't settled, would, as a general rule, would you open up and see whether there's a leak and then try to close it, or would you go for a VP shunt?
No. I would primarily go back in and see why there is a pseudomeningeal seal. It sometimes can happen that you missed an area where there was an opening in the dura that you didn't appreciate during the first procedure. But as mentioned, in many of these cases, I put in an external ventricular drainage because there is a difficulty. Usually they develop, if they develop somewhat later and not immediately, there is a CSF disturbance.
Okay.
There is a problem. Usually it is a sign of there is something wrong going on. So either because of the blood, fourth ventricular outlet closure, as Dr. Edwards was saying, or some kind of low-grade infection, it can be the cause of that.
So you will put an EVD out, try to see whether that sorts it out before taking the EVD out and then seeing it. Am I right?
Yes,
Thanks.
yes. And I absolutely go in again to know why is this leaking? And not just saying, okay, put in a shunt and then we have no problem with that meningocele anymore.
Thanks. Thank you.
Karen, can I answer? Can I
Sure,
comment?
please. Thanks.
It's a little bit different experience here because again of the logistics and the infrastructure problems that we have. So most often when we operate this posterior fossa, a small pseudomeningocele, sometimes just local pseudomeningocele, we first do a CT scan and rule out any hydrocephalus. So if there is hydrocephalus, there is no question that maybe you will need to do a VP shunt. We mostly use Chabra, medium pressure VP shunts, and that solves the problem. But if there is not a significant hydrocephalus, by hydrocephalus I don't mean small ventricles, not hydrocephalus, but patient not clinically symptomatic for hydrocephalus. So what we do is we usually, after doing a CT scan, we either just aspirate and give a tight bandage. Sometimes it solves the problem, or do a lumbar puncture and see whether the pseudomeningocele decreases. So if the pseudomeningocele decreases, then we know we do a couple of 2 or 3 or 4 lumbar punctures. Now that is maybe a little bit controversy in different centers, but we try to avoid assembly as far as possible. So do 2 or 3 lumbar punctures. And if the pseudomeningocele decreases, what happens is that there is a sprinkling effect at the dura because we are puncturing the dura at 2, 3, 4 points. And then the pseudomeningocele completely disappears after 2 or 3 lumbar punctures. If that doesn't disappear, then sometimes we might have to resort in very less, very few, a cystoperitoneal shunt. So that's big pseudomeningocele when we know that there is a big dural opening or a big defect there. So do a cystoperitoneal, that solves the problem. So opening up the posterior fossa again is a little bit, we would keep it at the last, So most of the time from a simple drainage and tight bandage and then it resolves, or VP shunt or a thicoperitoneal shunt. So sometimes if the patient are not obese or they are not cooperative, not cooperative for a lumbar punctures, then we do a thicoperitoneal shunt because we know that the pseudomeningocele has decreased after the lumbar puncture and the posterior fossa is wide open. So we're not bothered about herniation at the foramen magnum level. So these are the tricks we use as again case-based. But I'm sorry, I've never been exposed to try to use the programmable or gravitative anti-siphon devices.
No, I can imagine, but possible. I mean, if we treat hydrocephalus here, we have the gravitational shunt indeed. Yeah. And I mean, this is what we have available. But interesting, a cystoperitoneal shunt for pseudomeningocele, I have never used indeed. But we were discussing here the pseudomeningoceles that are really, really disturbing the patient, really bulging here.
Yes.
And to be honest, just local puncture and having a compressive bandage here, in our place, that bandage never stays properly positioned. It's so difficult to do that. I mean, that's so difficult.
So that would be a smaller pseudomeningocele. If it is a big pseudomeningocele,
no, the smaller ones are and not another issue. We really have to deal with the big ones, and for me, those point to a CSF circulation problem.
Yes.
Mr. Richard Edwards, do you have any thoughts, please?
I think pseudomeningoceles, I mean, either, as Andre said, they either reflect an inadequate dural closure, and we try and get a meticulous dural closure with, and usually supplement that with a dural sealant as well. I'd certainly caution against, tapping pseudomeningoceles. I'm certainly aware of cases from a medical legal perspective where attempted dural drainage with percutaneous puncture has resulted in brainstem injury. I've seen that in the medical legal case. So I think people have to be a little bit careful about rushing into those. It can be a hazardous procedure, and certainly should use ultrasound guidance or something like that if you're going to do that. In general, I think, as Andre said, I think it reflects the development of hydrocephalus. The CSF is going to take the path of least resistance, and often bursting through the wound is the simplest thing for it to do. And in those cases, I think they do need often need a shunt. I'm not a fan of tapping them. I mean, lumbar punctures are another way of sort of temporizing them often, but if there's a big communication between the pseudomeningeal seal and the intradural space, but often they will need a shunt. Going back to the comments on shunting, I mean, I think one of the biggest problems we've got is often children end up over shunted, and I think with programmable valves, we probably need to think hard about how we program those, and I think there's a general drift to higher settings on them to try and mitigate that. Those are my thoughts, really.
Thanks. Thank you very much. Just one point on from Professor Mazumdar's idea about putting cystoperitoneal shunt. Certainly not the posterior fossa. When I was training, we used to do that for the scalp large pseudomeningeal seals, and it usually worked, and then it just closed itself off. But I don't have much experience in the posterior fossa side. So last discussion, we'll come to Dr. Dieter Klaas. Dr. Dieter Klaas in his presentation mentioned about use of the VP shunt with the high pressure setting or virtual off to give intrathecal chemotherapy. Is that, I know that it's been done, but do you think that's, can you trust the virtual off? If a patient coughs or something like that, would the chemotherapy go down? What's your thoughts, Dr. Klaas?
Well, there are some technical questions I keep thinking about when a child with a tumor like an ependymoma or medulloblastoma is introduced by the pediatric oncologist with a question of intraventricular chemotherapy. So we sometimes wonder about some technical questions. As I mentioned in our presentation, it's very important to make sure the catheter is placed correctly right in the ventricular system, so that the drugs can distribute well in the CSF only. But the question is, how long should we leave, let's say, methotrexate in the ventricular system? When should the shunt be opened again, or the pressure settings readjusted? When I talk to the pediatric oncologist, they keep saying, okay, this is an interesting question, but there are still some open topics. So I appreciate a comment from the round on these technical things.
Thank you very much for raising this important point. Mr. Richard Edwards, do you have any thoughts on, if you do put the pressure up for the intrathecal chemotherapy, when you should then bring the pressure down, etc.? Thanks.
I think it's difficult to know exactly what happens, with these valves, because the virtual off is a setting of around 400 millimeters of water, so 40 centimeters. So there is a I think sometimes it can be higher than that. It's a bit variable, but there certainly could potentially be a risk that the drug doesn't go where you want it to go. If you're injecting it into a proximal reservoir, say, I guess it depends on how hard you inject it and so on, or whether you could exceed that pressure locally. We generally put a separate access device. And there used to be an on-off valve. I don't think it's in production anymore, where you could actually turn it off, and that would have been good for this sort of thing. But I think the virtual off, I think it could be used with caution, and it might still be better to use that. I'd be interested to know whether they, Professor Mazumdar, whether it's used in combination with a separate access device to give the chemo, whether you give the chemo through a separate access port and then just turn the shunt valve off. I'd be a bit nervous about injecting it into the reservoir and generating an intra-shunt pressure that might send the chemo the wrong way.
Professor Mazumdar, do you have any thoughts on that? Thanks.
No, yeah, I actually I don't have too much experience in injecting intraventricular chemo. Very rarely we have used it. But yes, most of the time we use the reservoir. Means we put if at all the chemotherapy is to be given, we put an Ommaya reservoir and we inject it through that whenever it is accessed. But not we have never used high pressure or a medium pressure shunt just to keep the that has never been a great issue with us.
So it was Dieter that was mentioned it. Sorry, my apologies.
Dieter, Dr. Professor Grottenhuis, have you tried? Have you had times when a patient has a VP shunt and then you put a Ommaya reservoir and then giving the intrathecal chemotherapy? And is there a worry that the intrathecal chemotherapy will go into the abdomen through that shunt?
Oh yeah, absolutely. I think that is certainly the concern. I have to say this was the first time in the presentation of the class that that points to all the difficulties here. I have the most experience in patients where we were asked to place a ventricular access reservoir so that the oncologist can give the chemotherapy. You have to make sure that that part of the ventricular catheter is inside the ventricle. That's number one. Then the way how you puncture it, because they will not puncture it once, not twice, not 3 times. It will be multiple punctures. So you have to be sure that it is not leaking there. And then we are at least I don't know about the dynamics and the kinematics of any type of chemotherapy, because it is different between cisplatin or methotrexate. It's not the same. And Dr. Klaas was already mentioning, if you ask the oncologist, they don't know at all how it is going through the CSF department. They say intrathecal, but intrathecal for most of it initially was through the lumbar puncture. The patients were supine or on the side. And then they were placing head down so that it would go there, but nobody was really aware of that. And it is simply not known. There is not a standard. It's different from one patient to another. So there are so much variables in this. But personally, I would be very reluctant to just so-called simply inject that into the reservoir of a VP shunt, because the reservoirs those reservoirs are not made for multiple punctures. At least you should do the least amount of punctures. It's an emergency situation that you puncture that. I always had this fight with the pediatricians that they had a child with a cough and some fever, was already known for 8 years having a shunt, and they say, "Oh, we want to have some CSF. Can we puncture the reservoir?" Well, that's a shunt system. Yes. I don't want to get a needle in the shunt system when it is not necessary. So then to know, I have done it twice actually by myself, that they ask me, you have to compress that it is not going to the abdomen or to the heart, but because one of the patients had a VA shunt, so that it is really going into the ventricle. It depends on how quickly you inject it, as Dr. Edwards was saying. All these variables we simply don't know. So from a practical standpoint, I would prefer putting an additional ventricular access reservoir, a real Ommaya reservoir, flat, which is more really constructed for multiple punctures, in the contralateral ventricle. I don't want to be even then I would try to compress the shunt system digitally with my finger while I'm injecting in the other side. But because we know when there is a shunt system, the whole CSF circulation is reversed. So the primary flow of CSF is towards that shunt. I mentioned this is differential pressure system. That's the system. It will go until the valve will close. It will go to the abdomen. So these are tricky things, and I personally I have no solution for this. I'm reluctant to do that, and I often tell those oncologists, I say, and I confront them with those questions and say, do you really know what is happening there? Because we have seen patients with severe encephalopathy after 5 courses of intrathecal chemotherapy, and they blame it to us. And they say, well, that was the wrong place, or well, that was the shunt, or it was this access reservoir was not placed properly. This is.
Would you do a CT scan every time? Would you do a CT scan every time before you inject?
Not every time, but certainly the first time. We learned it the hard way because if you ask a surgeon, even the senior resident, and say, was this inside the ventricle? Because we have to discuss with patients sometimes also the ventricular access reservoir with more or less normal size ventricles. We think that we have done it properly, but that's not true. We know that many ventricular catheters are simply not properly placed into the ventricle. So I said before something like chemo, intrathecal chemo is given, I do a CT scan with contrast to absolutely 100% sure that it is inside the ventricle. And even then, I shake the oncologist and said, you know that in the manual it said you have to inject this in 20 minutes. But like surgeons, they are not very time conscious. They inject it in 2 minutes, and that's too quick. You have to do this very, very slowly, because if you do that, it rapidly goes there. And actually also there's one other trick. I don't know if Dr. Klaas say the same. I say you have to wait 48 hours before you start injecting that after insertion, because otherwise it can quickly go retrograde along the catheter into the brain tissue. You have to wait 48 hours.
Thanks. Professor Groton, here's just a question. You said that so on a CT scan, you see the ventricular catheters in the ventricle.
With contrast.
Why would you give if on the CT that it is in the ventricles, why would you still give contrast?
No. Well, you think it is in the ventricle. Yes, it is in the ventricle. And now I give contrast. And what I see, the contrast goes into the ventricle, and a little bit of the contrast goes into the brain.
Okay.
Because we have ventricular catheters that have for 2.2 centimeters openings in the distal part. So
absolutely.
then the upper 8 little holes are still in brain tissue. And then the majority of that catheter is, I want to see with the contrast that there is no leakage, of contrast going to the brain. Then I tell them, wait 48 hours. Now it's your patient. You can start treatment.
Thanks. That's a great point. Thanks. Just 2 tips that I came across. One was that I was speaking to one of the vendors a couple of weeks ago, and I talked about using a needle into the reservoir, shunt reservoir, and she said to me, you need to use a non-coring, according to them, you need to use a non-coring needle. So the needles that we use, the hypodermic needles, they are coring needles. They take a core out. Whereas the idea is non-coring needles. Is that why Dr. Dieter Klaas, you mentioned about this TUI needle?
Yes, that's a special device for puncturing a reservoir or a port system. And this has the advantage you mentioned already, Naren, that the substance is not damaged in a way, and it makes several puncture procedures easier to avoid leakage. And this is, as Professor Groten, who says, it's a big problem really, which can bring us to an infection with the necessity to take all the systems out again. That's really an experience we have every now and then. So I think these procedures have to be taken very seriously, and I appreciate the comments from the round, because every now and then we see the oncologist, he shows us the protocol, and in the protocol is written, okay, you must do this, you must offer us the possibility for intraventricular chemotherapy. And there are so many unsolved questions, and I appreciate the comments from this round really very much.
Thanks. Thank you very much. Thanks for that point, Dr. Klaas. Just one other point in terms of aspirating from a reservoir or injecting from a reservoir. This is a general tip that I learned from Professor Martina Messenger. She uses this in neonatal patient. This is slightly different, but I think the principle could be applied. She advises them to make a cross over the dome of the reservoir. So there are 4 sectors. So if they aspirate from one sector, the next time they aspirate from the diagonally opposite sector, and then so this way, each time it's from a different place that the dome is aspirated from. And if you look at the literature, that the idea is that to put a needle not at 90 degrees, but up to as low as 25 degrees. I presume that's to get a more longer course through the wall of the dome. So these small techniques, but sometimes they make the difference between having a problem and that you don't want.
Especially, sorry, a little other trick. Especially in younger children, it's very easy, and even in adults. Before you puncture with a needle, and you can use just the smallest lumbar puncture needle that also have a core, so it's non-coring. But move the skin over the dome of the shunt, then you do the puncture, and then you let the skin go again. So the skin will cover the place where you punctured the dome. So this is very simple. We have to do it all the times when we do this also with Omaya. Move the skin a little bit over that dome. Now you do the puncture. So you stretch the skin over it. But the moment you remove the needle, you let the skin go back. And then it covers. So you will never see any drop coming out of the skin. All these little tricks you really have to use, like the non-coring needle, the Tumours needle. This is essential. It sounds so easy, but you can do a lot of things the wrong way.
That's brilliant. Thank you very much, Dr. Klaas, and all the people who discussed, and thank you for the participants. So this brings us to the end of this session, this day, and this course. Before I give my final remarks or closing remarks to summarize, it has always been the tradition that Professor Grottenhuis, being the senior surgeon, in Britain we say the father of the house in Parliament, and same goes here. Professor Grottenhuis, father of the webinars and the list. Professor Grottenhuis, can I please ask you to give your closing remarks, please? Thank you, sir.
Now you make me feel old.
No.
No, but no, you're right.
Wise.
40 years in neurosurgery, that means it is indeed, you have seen a lot. Now, Naren, there was 4 days. I mean, you have, as with many other webinars that you organize from the listserv, really covered current issues in a certain area of neurosurgery. Now it was pediatric brain tumors, but also today the controversies. An excellent way of open discussion. Maybe next time I think we should try to involve even more the participants, because I have seen in the chat room sometimes a few questions, but we haven't addressed that. So it should be, I know it's not always easy, but it should be a kind of more interactive way to do that. Nevertheless, I think that everyone who listened to it could have get some of the pearls in clinical practice. And that's the wonderful thing here. It is very practical, very to the point, to something that we really can use in practice. Like this beautiful overview of Llewellyn of intraoperative imaging, that's this is so practical. This is what we need. And all these tricks that Dr. Klaas give today, Dr. Muzumdar beautifully really brought us to this intriguing problem of cerebral mutism. I mean, this is really, really worthwhile, the time that we spent here on a Sunday afternoon. And I think the fact, and I mentioned that yesterday, the number of participants is consistent. They don't leave before the end of this all, and that's therefore I again congratulate you with all these efforts that you do, Naren.
Thank you very much, Professor Groterius. Thank you very much for your support. You know, it is you know, you can't do this without the support of the faculty, the participants, and it is a teamwork. And I think these small things that we learn, the big things that we learn, but main things is that it keeps our brain open to ideas. We are not, you know, getting our own small ways. It's nice to know how different people do and keep the brain tilled, so that, you know, that we can understand different perspectives and have, you know, come with new ideas. And I think we had 4 days of this course. It was ambitious, and at what point I said, oh boy, why did I get into this? But I'm at the end of this, I'm really glad that it was done, and I hope either me or someone else will do it next year. I think the first day we had a unique day of neuropathology and molecular biology, which will more and more be an important aspect of pediatric neuro-oncology. We had pathologists, we had you know, world-class pathologists, world-class scientists, world-class neurosurgeons, and world-class neuro-oncologists taking us through the molecular biology. The second day, we had 15 lectures covering every aspect of all the major tumors from experts in a very succinct and way that for any resident, any fellow, any junior surgeon, even any senior surgeon, it's like a textbook, because all those are recorded. They are on the YouTube, so anytime you can go and look through it as if it were, you know, if it's a book, you will look through it. In the old days, there was a lecture, was done and dusted. You can never get it back. Here, the lecture is there, so you can always go and look back at it like a book. And then yesterday, we had the keynote lectures from world-class surgeons and neuro-oncologists on from education to global neuro-oncology to how to reduce burden to fantastic cases we all discussed. And then we had today, you know, the controversies from which we learn and we progress. So I think it has been rewarding for me to do this, and I really thank everyone for the support. As anyone who has worked with me know, usually I nowadays can't think beyond 3 weeks ahead. So these are planned at short notice. But thanks for everyone's for support. I think that's neurosurgeons able to quickly jump into and get things done. And I wish you all a great evening. And this will be also on the YouTube, so you can refer, you can get your residents to look at it, you can get your fellows to look at it, you can look at it yourself. So until next time, as God wills, and wishing you all a safe evening and a lovely week ahead, and wishing you a good day. Thank you very much.
Thank you so much, Naren, and
thank you.
Great seeing you, Richard and Llewellyn, Dieter, Data, with amazing. Very lovely to see you all.
Thank you very much for all the
good everybody.
I really appreciate it. Thanks a lot.
Cheers. Well done, Naren. Great job.
Thanks. Thank you very much. Cheers. Thanks. Thank you again, as to Professor Musumdar, Llewellyn.
Thank you very
class.
much.
It really was great. Thanks a lot. Thanks, Dr. Class. Thank you very much. Hope you enjoyed it.
You are welcome, Naren. Thank you very much for all you did for us.
Thanks.
Have a good time.
Thank you.
All the best.
All the best. Thank you. Bye. Thanks, Professor Musumdar.